I guess we could go ahead and get started. I wanted to share something with you guys first because renal and the kidneys is near and dear to my heart. I was actually born with a genetic kidney disease, and it progressively caused a decrease in my renal function. And not that long ago, I was in end-stage renal failure, stage 5 renal disease. I was on dialysis, and the idea of going to med school was bleak. And my aunt actually came forward and donated her kidney to me. And that is why I'm here today. That's why I'm in med school. That's why I'm with you guys. So she absolutely saved my life, and just a shout out to her. But for you guys, I just wanted to say this, as you culminate the end of term 1, I think it's easy to lose the forest for the trees, right? You're so focused on the little nitty gritty things, you forget the big picture. And the big picture is that you're doing this to eventually help people, and not just kind of help people, but like really change people's lives. And that's the whole goal here. That's why you're going through this. And I just want to say, I know many of you like me have seen the hospital bed from the other side. And just remember, your patients, they don't care how many big words you can pronounce or how many diplomas you have on your wall. They just want a friend. They want someone that can suffer with them and someone that could persevere with them. So with that being said, we'll get started. And y'all are going to do great on your finals too. So power to the people. Let's see. All right. So we're going to get started with, as you know, this is the page, and everything's going to be posted there. I posted some extra stuff here, along with my shorthand notes for the test, so you can go look at that. I've got the equations page and everything that you need to know. So we'll start off with some anatomy, some basic things. Remember that the right kidney is a little bit lower than the left, and that's because of the liver there. Some important anatomical landmarks: that left renal vein is going to sit right underneath the superior mesenteric artery. And that's how you get that nutcracker syndrome, right? If there's an acute angle of the superior mesenteric artery, it can actually cut off blood flow to the kidneys. Another thing, this left testicular vein goes straight up into the left renal vein, whereas the right testicular vein goes into the inferior vena cava. So just remember that. And we're going to talk about some other landmarks here that are important for surgery and stuff like that. Again, remember that right kidney is a little bit lower than the left. It sits about T12 to L3 or T11 to L3 between the two. And then when we go to the inside, to the anatomy, the general principle is that if you get blood flow up here to the cortex, you can filter it out through the convoluted system that you've seen. And then eventually you get into the urinary system, so you can get it to the bladder and excrete it. So we kind of mentioned EPO in the beginning, erythropoietin. And remember that when the body's hypoxic, it's going to signal the kidneys to release erythropoietin, and it's going to cause increase red blood cell production, so you can get increased oxygen carrying capacity. We're going to cover the RAAS system in detail, and keep in mind that vitamin D is converted to 125 vitamin D, active vitamin D. So if you have chronic renal failure, you might not have 1-alpha hydroxylase, and if that's the case, you can't fully activate vitamin D. And we're going to get into, obviously, we're going to get into this in more detail, but we're going to excrete waste. It does, along with sodium, control the water and electrolyte balance, and then acid and base as well. This was kind of helpful for me. You kind of go large to small, and it kind of breaks it down, just in case they ask you a question specifically on what goes to what, and then back from small to large when we go back out. So I would just try to commit this to memory as well. I picked out some of the embryology that I felt was important. Remember that when we're talking about that urogenital system, we're talking about intermediate mesoderm. So that's where it comes from. Primarily, we're going to be worried about the metanephros. So you're going to come across terms like paramesonephros and mesonephros. That's more of the reproductive system. When we talk about the kidneys and the permanent kidneys, we're talking about the metanephros. And you can see that it all comes off of this uteric bud. So the drainage system is going to be the uteric bud, but the kidney is going to come off of it's going to butt off of it. And you can see that here. So the whole goal in making the kidney is that from the drainage system, this pink area is the uteric bud, and the metanephros, or the metanephric blastema, or the mature kidney, is going to butt off of it. So in order to make a proper kidney, final kidney, you have to have this uteric bud. So that pink area right there, let me go back. That pink area is all this brown area. That's the drainage system. And the kidney is going to butt off of it, right? So we're going to look at some problems that form when we do that. But first, remember that the kidneys have to ascend. They start in the pelvis and they go up. That's important clinically because there's a problem that develops as well. So yeah, this is just another overview of it. And let's see. So here we go. So remember, if you don't have that uteric bud that forms, the kidney has nowhere to grow off of. So you can get renal agenesis here. And there's some problems that can develop. Oligohydramnios. Think about the idea that the fetus can swallow amniotic fluid, but he has no way to alleviate it. He has no way to excrete it. So that can result in oligohydramnios. If that's the case, remember we talked about pulmonary hyperplasia. If you're not consistently swallowing fluid, you can end up with pulmonary hyperplasia, right? Because you're not the lungs aren't being developed. And Potter sequence is one of those classic scenarios they talk about with bilateral agenesis. But for right now, I want you to remember that this uteric bud has to form first, right? And then the kidney is going to grow off of it. Now, when it comes to that, they can give you two different scenarios. So if they could give you a question where they use retrograde dye and shoot it up retrograde into the ureters, and you can see whether, well, you want to ask yourself, does it actually have two ureters coming off of the bladder? Because if that's the case, then it was more of two separate uteric buds coming off of that stalk, okay? And that's why you get two separate ureters. But in here, you can see this is more of a later branching. So it's more like a bifid ureter, right? So you had that original ureter that comes off of the bladder, but then it separates. So this is more of a late division. Now, we talked about the ascent. I want you to keep this separate from the nutcracker syndrome, because understand embryologically, if you have this horseshoe kidney, this is how, obviously the kidneys are supposed to separate. So if it's supposed to ascend, it gets caught under the inferior mesenteric artery on the process of ascent. Now, the difference is that with the superior mesenteric artery, the nutcracker syndrome, the renal vein goes underneath it, but that's where it's supposed to be, okay? It's supposed to sit right under the superior mesenteric artery. This problem is that the kidneys didn't separate, so when they were ascending, it got caught under the inferior mesenteric artery. So make sure you keep those two separate. They could definitely ask a question about this. I went ahead and labeled these. So if we work inside to out, you have this fibrous capsule around the kidney, then you have this perirenal fat, then you have this renal fascia, and then you have pararenal fat. Peri meaning in, para meaning out. Okay, so they could ask you a question, a person is stabbed in the back, what is the first layer that is pierced? And they could ask you that, but they like that. But when we talk about renal transplants, you can see what they actually do is and that's how I have it done. They implant it into your abdomen, and you can see how difficult it is to get to the kidneys in the back, because there's so much musculature and fat. So what they tend to do is leave the kidneys in unless there's a reason to take them out, and they implant the kidneys into the abdomen and hook it up to the iliac vessels. But I have a slide to show y'all in a little bit. Okay, so when the patient's laying down, especially during trauma, you want to analyze this. So if the patient's laying down and there's some sort of intra-abdominal bleeding, there are dependent places, like the lowest aspect or the lowest place where blood can accumulate. So when the patient's laying down, they check for in the hepatorenal recess for blood, because when you're supine or laying on your back, this is where blood could collect. So this FAST test is one of those trauma tests to say, okay, is there any intra-abdominal bleeding? Because if there is and the patient's laying down, we would expect to see blood there. Another name for hepatorenal recess is Morrison's pouch. Okay, so if they talk about Morrison's pouch, that's the hepatorenal recess. Okay, and as for referred pain, if someone gets flanked, has a kidney pain and it's referred, it's usually referred in the derivation of the iliohypogastric and ilioinguinal region. So you might get pain that runs along that area from about T10 to L2.
Hey, Brady, could you please go back for the hepatorecess thing again?
Yep. Yeah, sure. So
Thank you.
sometimes, especially during trauma, a lot of times the doctors are worried about some sort of intra-abdominal bleeding or fluid accumulation in the abdomen. So if a patient is laying down supine and you want to check to see if there's any fluid accumulation, when the patient's laying down, a lot of the fluid's going to develop, it's going to end up here in this hepatorenal recess. So you can use an ultrasound and you can check to see if there's fluid there, because that may be indicative that there's some sort of intra-abdominal bleed. And another name for this is called Morrison's pouch. Okay, so yeah, no worries. So you may have heard of this water under the bridge analogy. This is really important surgically. So the water is the urine or the ureter that goes underneath the vessels. In a female, it's the uterine vessels, okay? And you can ask yourself, well, why is that really important? Well, if a woman gets a hysterectomy, meaning she gets her uterus taken out, they need to ligate or cut off the blood supply to the uterine vessels. But the surgeon needs to remember not to go too deep, right? Don't get to the water portion or the urine portion, because you don't want to ligate or cut the ureter, right? You just want to cut the uterine vessels. So that's why they talk about the water under the bridge. The water is the ureter or the urine, and the bridge is going to be those uterine vessels. Now in a man, it's not as super clinically relevant, but it's the same thing that happens. The water underneath is the ureter, and what crosses over is the vas deferens or the ductus deferens. Now, there are 3 constriction points you need to be aware of, and these correlate to where stones can develop. So obviously kidney stones are a big thing, and there are constriction points along the ureter where the stone can get lodged. So the first one is the uretopelvic junction. It's right at the base of the kidney. There's a constriction point there. There's a constriction point where the ureter crosses over the iliac vessels. And there's a constriction point where the ureter enters the bladder, the uretovesicular junction. So what they could do, they could give you a picture. A patient drank some fluid, right? Some dye, so that they could see it. The dye gets to the kidneys, and then they show you that one of the ureters is dilated, right? So and that would be indicative that there's a stone lodged. And so all of the fluid is accumulated or backing up. And that can actually cause what's called hydronephrosis, or water in the kidney, right? Because it can't drain. So making sure these stones don't get stuck are super important. But just remember, if they give you a slide that has a dilated ureter, you're looking for the point where fluid can't go, because there means there's a constriction point. And you can see that here. So this is just a regular CT, but it's a calcium stone. So you see it's lit up. So this is that uretovesicular junction. But look how dilated the ureter is, right? So it's so dilated because the fluid's coming from the kidney and it's getting stuck there. It can't get to the bladder. So that's a huge problem. Like I said, it can cause hydronephrosis. This question mark they're asking about is the uretopelvic junction, right? Or that constriction point. But you can see the stone here, everything's backing up from that point. And then lastly, for the embryological stuff, remember that when the child's a fetus, a lot of the drainage goes to the umbilical cord. So if that doesn't seal off completely, you can get a urachal fistula, which means the urine's draining out of the umbilicus. You can get a sinus where it kind of, it's not completely patent, it closed off, but it does have a little bit of drainage, or you can get a cyst. That's a urachal fistula, and they could ask you a question about that, but you're worried about the urachus that didn't close off after birth. Okay.
So a question, actually. For I think it was the diagram before, looking at the different junctions. So do you mind pointing out where we'd see the junction where it's going over the common iliac?
Yeah, right here.
Okay,
You can
cool.
see how it dives over right there.
Yeah. All right, perfect.
Yeah.
Thank you.
Yeah, no worries. All right, some of the clinical anatomy. So you're going to worry about some of the reproductive organs and stuff. So we'll just focus here. You can see the bladder here. This is called the rectouterine pouch, also called the pouch of Douglas, a highly underrated pouch in the body, in my opinion. But Lindsey gets my jokes. Never mind. It's a funny pouch. But anyway, so if the patient is standing and you get intra-abdominal fluid, this is where the fluid's going to accumulate. Okay, so you can do what's called a coldocentesis, and you can actually aspirate the fluid out. But if the patient's standing and there's some sort of intra-abdominal fluid accumulation, remember, if they're laying down, it's the hepatorenal recess, pouch of Douglas. If they're standing, it's going to be, or at least in a female, this rectouterine pouch, or the pouch of Douglas. Obviously, men don't have a uterus, so they don't have this pouch. They have a rectovesicular pouch, right? Between rectum and bladder's vesicular. So they'll have a pouch as well. But just remember this, the other name for it is pouch of Douglas. Now, the autonomics obviously control a lot of the urination of the bladder. So when we talk about parasympathetics, we're talking about going to the bathroom. We're talking about peeing, right? So it allows you to go to the bathroom. So the parasympathetics are going to constrict the detrusor muscle, constrict the muscle around the bladder, and it's going to relax the internal sphincter, right? That's what you're supposed to do when you pee. So you contract the bladder and open the sphincter so you can pee. Now, remember the external sphincter, you know, when you really have to go and you have to hold it, that's under that skeletal muscle. So that's under somatic control. You control that yourself. But the internal sphincter is smooth muscle. Now, sympathetics obviously are going to be opposite. So they're going to contract the internal sphincter to prevent you from peeing, and it's also going to relax this detrusor muscle, right? So you don't pee. So remember, parasympathetics help you go, and sympathetics will prevent you. And visceral afferents, remember that visceral means organ, afferents are sensory. So stretch, not only pain for visceral afferents, but this stretch sensation is going to be from them. Okay, the reason women get UTIs more than men is because the urethra is smaller, right? So there's just a decreased distance that has to go to start an infection. What's important for the guy to know about the guy is that if you have to do a catheter, there is a major constriction point here. And so not only does it turn up like this, but it's also a constriction point in the membranous urethra. You will get into that more next term, but I don't want them to catch you by surprise with a question about this. So right there, that's the membranous urethra, and that's if they say you reached a point where you can't put the catheter any either further, it's there. Obviously, if the patient has prostate enlargement, that could be a problem too, but that'll be more next term. PKD, so these patients end up having really large kidneys and they eventually get renal failures and require a transplant. There's an autosomal dominant form and an autosomal recessive form. The dominant form usually presents in young adulthood. So this is actually how they do the transplant these days. This is how they did it for me. They make an incision right around McBurney's point by your appendix, and they just hook up the transplanted kidney to your iliac vessels. And if the kidneys, the natural kidneys aren't causing a problem, you know, they don't worry about going in. But either way, it's a separate procedure to take these out than it would be to put the transplanted kidney in. But it's easy access. They use the transplanted ureter and make a third ureter that goes right to the bladder, and all is well. Stress incontinence. So obviously that makes sense. If you have a lot of stress on the bladder, it's going to be hard for that internal sphincter to stay constricted. So when you talk about incontinence, you're talking about decreased ability to hold your urine, right? You're incontinent. You can't control your bladder, and stress is going to be a major cause of that. And lastly, a cystocele basically just means the bladder has prolapsed into the vaginal canal. So if this happens, if you get a cystocele, you need it surgically corrected. All right, now, I know histology is a pain point in general, but for renal, it's a big one. So what I tried to do is we're going to walk along the nephron, and I'm going to show you pictures of each segment and how to recognize it. Okay, so if y'all have any questions, just speak up, but I'm going to try to point out the things that are important to know. So obviously we have the cortex and the medulla. So we're going to start out with the glomerulus, right? It's our major tuft of capillaries. So remember, there's these little slit diaphragms right here that are basically just really small filtering points. And when you filter the blood right here, you get urine in Bowman's capsule, right? So I believe only about 10% every time the blood cycles through your body, only 10% actually gets through to the kidneys to the glomerulus to be filtered. But there's over 2 million of these glomeruli in the kidneys. So each of these have these little slit diaphragms, and it's going to allow these molecules to come through into the urinary system. So when you see this picture, this tuft of capillaries, that's the glomerulus that we're talking about. And you can see here in the electron micrograph that these little tiny little slits allow particles to go through. Now, some things you can help to clarify what goes through by charge. So negatively charged molecules are pretty much repelled. Size obviously is going to matter. So large molecules are not going to go through, such as like albumin, and then shape, of course. So blood cells aren't going to be able to go through. So it helps to differentiate what's the kidney's going to filter and what it's going to let stay in the blood. Okay, so one of the major differences you need to know is how to identify the proximal convoluted tubule versus the distal convoluted tubule. So for the proximal convoluted tubule, you can see it here. The way I try to remember it is it's pink and the nuclei are sparse. Okay, so we're going to go over the physiology a little later about the PCT, the whole nephron. We'll go through it, but I just want to focus on the pictures for now. So you see the glomerulus here, this tuft of capillaries, and you see this proximal convoluted tubule here. When you see it next to the distal convoluted tubule, it'll help differentiate it. Okay, so you see here, this is a little bit of a weird stain, but you see the proximal convoluted tubule, there's sparse nuclei. These are the glomeruli. Again, glomeruli, and this is the classic picture of it. So you see it's very pink and it's got sparse nuclei. So keep that in mind when we get to the difference between the proximal convoluted tubule and the distal. But first, as we walk along, we'll get to the loop of Henle. So remember, the proximal convoluted tubule, you're primarily worried about getting back in everything you don't want to pee out, such as glucose, amino acids. That's the first job. Get everything back, then we're worried about the water and salt balance. So now we're getting down to the loop of Henle, and we're going to start worrying about that countercurrent multiplier, right? We're going to start getting solutes out and getting fluid out. So now when we look at the loop of Henle, what helps me is you can see it's a very white space, right? The nuclei on the edge are sparse. They're not there. So keep that in mind. That's what we're looking at here. That's what we're looking at here. It's very white, and it's very, the nuclei are kind of scattered about. And that'll help you when we get a little further. So again, you see it's very clear, this loop of Henle, very clear. Now the thing that's next to it is the vasorecta. And the way I remember the vasorecta is look for blood cells, red blood cells. So if you remember, this countercurrent multiplier kind of makes sense right here, because you have stuff in the urinary system in the loop of Henle and stuff in the vasorecta, right? Blood in the vasorecta. So you have this countercurrent multiplier jumping from back and forth. Whether it's fluid or solutes or sodium and stuff. So remember, the loop of Henle is going to be this really clear space, and if you're looking for the vasorecta, you want to find the red blood cells. Now, again, this is a little bit of a weird slide, but the vasorecta you can see is a little bit darker versus the loop of Henle. Okay, and then here is a good example of it. So we see the loop of Henle here, the very white area, sparse nuclei, and then the blue is pointing to the vasorectum. You just look for those blood cells, see the blood. All right, now we get to the distal convoluted tubule. So the thing we want to differentiate here is proximal convoluted tubule versus distal convoluted tubule. So first of all, know that there's 6 proximal convoluted tubules to every 1 distal. Okay, so you're going to see a lot more of the proximals than you are distal. So remember we said it's the proximal convoluted tubule is very pink, sparse nuclei. Now, conversely, the distal convoluted tubule is a lighter pink and it's got more nuclei. So you could see those here, right? Distal convoluted tubule versus proximal, okay? Distal versus proximal. That looks like a distal right there, proximal, distal. So you could see that, and I have some zoomed in pictures coming up. Okay, so like here next to each other, this is perfect. So you could say this is a proximal convoluted tubule. It's pinker, there's less nuclei. This is a distal convoluted tubule. It's lighter staining, there's more nuclei. Okay, so keep those in mind when you're trying to identify these. Now the macula
on the previous one.
Yeah, sure.
Why does the slide itself say that there's less mitochondria? I thought the DCT had more mitochondria because of all the sodium, potassium, ATPs.
That's a great question. I don't know. I don't know why the I pulled this straight from lecture, so I'm not exactly sure.
It's in ours too. That's why I was confused.
Yeah, I'm not exactly sure. You have to clarify that with the facilitator for sure.
I was told in small group that by our facilitator in small group that they're comparing it, the lesser mitochondria in comparison to the proximal convoluted tubules, because you have a whole lot more happening within the proximal convoluted tubules. So, and then there's also the transmission electron micrographs that show like the apical nuclei and the mitochondria really well between the distal and proximal convoluted tubules. And you see that you actually have more in the proximal. So I think it's saying there's still mitochondria in the distal, but less in comparison to the proximal.
Yeah, I mean, that makes sense. When you're thinking in the proximal, you're trying to take in all that glucose and you know, all the amino acids. That would make sense, but I would, you know, I can't say for certain, but that does make sense. Thank you. Okay, so now the macula densa, it's kind of tricky because it's always lays next to the glomerulus, but it is part of the distal convoluted tubule. So just imagine the tube is going down and the distal convoluted tubule kind of sits up against the glomerulus. Now, what the macula densa is going to do is it's an osmoregulator. So it's going to recognize sodium, and wherever sodium is, water is. So by recognizing sodium, the amount of sodium, it could kind of justify how much water's in the body. And by doing that, you can take measures to keep water or get rid of water. So when we look at this picture, you can see it always lies next to the glomerulus, right? But it is part of the distal convoluted tubule, and it's going to regulate your salt water balance. Super important slide. So now, one of the important things the kidney does is regulate your water or your blood pressure, right? So if it recognizes that you have low blood pressure, it wants to do two things. It wants to constrict the vessels, therefore increasing the blood pressure so you can keep blood flowing. And you also want to start reabsorbing more water so you can bring the blood pressure up, right? Bring the fluid up, because typically low blood pressure correlates to low volume or hypovolemia. So two things you want to do. You want to constrict the vessels to immediately raise the blood pressure, and you want to start resorbing or reabsorbing water. So what they do is what the kidney does is use this RAAS system. So renin is going to be released, and through a process, it's going to activate angiotensin 2. ACE is one of those interesting enzymes. They use it in pharmaceuticals because you can give ACE inhibitors to help with high blood pressure. Anyway, ACE comes from the lungs. Don't ask me why, it just does. But the point is that you're going to get angiotensin 2. And I think of tensin as tensing down, right? It tenses down on the vessel. So what the angiotensin is going to do is it's going to raise your blood pressure by constricting the vessels. Now, the other thing that this does, the other A is for aldosterone. Now, aldosterone is going to work later on in the tubule to help reabsorb sodium. Now, by reabsorbing sodium, you're pulling water in. And we'll get through that in a little more detail. But just make sure you understand that by releasing renin, we're using two mechanisms to help bring the blood pressure up and bring the volume up as well. All right, so we're going to get into the collecting tubules and some of the images. let's see, I have a good one. Okay, so now we're going to have all three next to each other. So the proximal convoluted tubules and distal convoluted tubules are circular, right? But when we talk about these, the loop of Henle, the vasa recta, and the collecting tubule, they're all going to be sort of parallel to each other. So remember, we said the loop of Henle is very clear, right? The vasa recta, we're finding the blood cells. And then for the collecting tubules, opposed to the loop of Henle, it looks kind of grainier, right? And you have more nuclei in the walls, right? So when you compare the loop of Henle to the collecting tubules, the loop of Henle is very clear compared to that. And again, the vasa recta is going to have the red blood cells. So I took this picture and I zoomed this one in so we could just go through it. See the very clear area, sparse nuclei, we're thinking loop of Henle. Next to it, we have that collecting tubules. It's a little bit grainier. And then wherever you see these bright red blood cells is going to be the vasa recta. So this makes sense, right? Because we need these next to each other for that countercurrent multiplier. You constantly want to be exchanging stuff. So by the end of the tubule, once you get to the bladder, you have the proper amount of fluid and solutes out that the body needs. Now, we're going to move on to the drainage system. So one of the key things about the ureter and the bladder is that it's the only place in the body you're going to find this transitional epithelium. They talk about these umbrella cells or these dome cells. So in the bladder, they dome up when the bladder's empty, but when the bladder's distended, they kind of spread out. It allows the bladder to distend. But keep in mind, take a snapshot of this picture and know that transitional epithelium, you're only going to find this in the urinary drainage system. So the ureter has like this stellate formation. It's got the transitional epithelium. It's going to drain into the bladder. And you can see the bladder here. It kind of has these dome cells, and that's the you know, it's going to obviously hold the urine. And then you keep this transitional epithelium all the way till you get to the end, right?
I have
And
a
then
quick
it's
question.
yeah.
So I get confused. So do we see the domed shaped cells when the bladder is empty or when it's full?
When it's okay, when it's empty, like they dome up because it's empty, but when the bladder's full, they kind of spread out, and it allows the bladder to distend. So you're going to see this dome formation. You can kind of see it here, this doming up. That's because the bladder's empty. You can imagine when it spreads out, when it's full of urine, that it's going to kind of stretch out and you won't see the doming. And as I said, transitional epithelium, yeah, no worries, till you get to the very tip, and that's going to be stratified squamous epithelium, male and female. All right, so we'll get into some of the glomerular filtration and the math part of this. So GFR is the main constituent to how you measure how well the kidneys are working. How well are you able to filter? So basically what you're asking is, this is a constant, and this is going to ask you, what is the filtration? Are we filtering fluid out? Or are we reabsorbing fluid? So that's going to define what the GFR is. Okay, this is a super important slide, so I'm going to try to go slowly through this. So the capillary is going to have two important pressures involved with it. It's going to have the hydrostatic pressure that's going to push fluid out of the capillaries. It's also going to have the oncotic pressure. Now, the oncotic pressure is determined by the amount of proteins in the actual capillary. These proteins are going to give a pulling effect. Okay, so you have opposite. You have a hydrostatic pressure that's pushing fluid out of the capillaries, and then you have an oncotic pressure, which is the proteins in the capillaries that's helping to pull fluid back. Now, you also have the same two mechanisms in the interstitial fluid, in the fluid around the capillaries. It also has a hydrostatic pressure pushing and an oncotic pressure pulling. Okay, so you can see that here. This is the capillaries. The push from the capillaries is hydrostatic. The pull into the capillaries is the oncotic pressure, which is determined by the amount of proteins in the capillary, particularly albumin. And the reason this is so important is because there are clinical applications. Like y'all learned about kwashiorkors malnutrition, which is a protein malnutrition. So these children don't have enough albumin or protein in here to get this pulling effect. So what happens? The hydrostatic pressure overwhelms. So they get ascites, they get swelling, they get edema. This happens with people with liver failure too. They can't make these proteins, they can't make albumin, so you don't have enough oncotic pressure to pull. So the hydrostatic pressure overwhelms. That's why you get edema. Now, if you say Bowman space, it also has a push factor, which is hydrostatic, and a pull factor back to Bowman space, which is oncotic. So just remember, hydrostatic is push, oncotic is pull. They did give y'all an equation for this. This one it's exactly the same. I promise I pulled this from first aid. I prefer this one because it's all negative signs and you keep the hydrostatic pressures in with one and the oncotic pressures with the other. So use whatever works for you. This one's just, that's just how I do these equations. Okay, so again, this kind of defines it. You can read this on your own, this pressure, this hydrostatic pressure versus the, yep.
Sorry, what's sigma in the last one?
Yes, that's a constant. So they could actually give you that. It's the same as KF. They can give you that. If they don't give you that, then assume it's 1. But they're two different constants.
Okay, cool. Thank you.
Yeah, I just put this in for completeness sake. Like for the boards, they could ask you this stuff. But if they don't give you KF or sigma, then just assume it's 1. I put it again here for this filtration. This is the way, I guess, that they teach y'all to do it. But again, the way I do it, like I said, constant, but then you're just subtracting the hydrostatic in the capillary minus the hydrostatic in the interstitial, the oncotic in the capillary minus the oncotic in the interstitial. I don't know. I just find that easier. So now, this is clinically similar to kwashiorkors, but it's a little bit different. So remember when we talked about that kwashiorkors, it's a protein malnutrition. So they don't have enough protein in the capillary. So the hydrostatic pressure is going to push the fluid out. For kids with, or people with nephrotic syndrome, you're actually releasing a lot of proteins in the interstitial fluid. So the proteins in the interstitial fluid, there's so much of it, it's pulling the fluid out. So whether you don't get enough pull in the capillaries or you're getting too much pull in the interstitial fluid, the whole point is that you're getting a lot of edema, a lot of ascites because of that. So you can say like hydrostatic pressure kind of makes sense, you know, it's fluid, it's going, it's pushing, but this protein pull effect is very important clinically because you can see how much that pulling factor correlates.
Well, I have a question. In that case, will they have a higher GFR?
I know they go into renal failure. Will they have a high GFR? Yeah, I'm not sure exactly. I don't think we need to focus on that too much. This was just to illustrate the idea of the pressure. I'm sure that they will eventually get a decreased GFR to because of the protein that accumulates in the interstitial fluid. This overwhelms the system. Yeah.
So,
but yeah.
Sorry, go ahead, finish.
No, I was just going to say, once you get to term 4, you get into this much more. There's a nephritic syndrome too and stuff. So we haven't even covered that yet. So I'm not going to speak out of my lane. Yeah, go ahead with your question.
With the increase in oncotic pressure, if we have an increase in oncotic pressure, are we pulling in the water more?
Yes.
Okay.
Right. So this kid right here has an increased oncotic pressure in the interstitial fluid. So it's pulling it out of the capillaries into the interstitium, right? So that's why he's got this edema, because because he is releasing a lot of protein into his urine. I would imagine that this comes like you know, Elvis had asked, that this comes with a lot of consequences, right? Because obviously you're not supposed to excrete or secrete or filter protein into the urinary system. So the downstream effects of this are going to be significant.
So I have a question, sorry.
Yeah, go for it.
How come, I know like oncotic pressure deals with reabsorption, right?
Yes.
How come does it favor filtration here?
Because, okay, so because it's in the interstitial fluid. So you define reabsorption or filtration by the capillary. Okay, so let's see if I annotate this, if I could do it. So this child in the capillary, he has increased interstitial, he has increased oncotic pressure on the outside, right? And a decrease on oncotic pressure on the inside. So this is actually going to favor the fluid going out, right? So that's filtration, right? So because of all the fluid going into the interstitial fluid. So you define filtration or reabsorption by the capillary. That's why that's the case.
Yeah, both sides of the equation are going to have both kinds of pressure, both hydrostatic and oncotic. The filtration versus absorption, that's just based on which factor is higher. It's that equation, honestly, like in which side of the seesaw, like either the capillary bed or the interstitium.
Yeah, just remember that you define filtration or reabsorption by what's happening inside the capillary, not the interstitial fluid. Okay, and this brings up a good point. What happens if you get a negative filtration? What does that mean?
You're pulling more into the capillaries?
Yeah, you're absorbing. So saying a negative filtration is the same thing as saying you're positively reabsorbing. So if they give you a question on the test and there's a negative value, that just means it's going the opposite way. So a negative reabsorption means you're filtering. A negative filtration means you're reabsorbing. So I've seen questions like that. They just want to be tricky. So just know that the negative just means you're going the opposite way. Okay, so we talked about this. This is kind of when you get a urinary stone. So here you can see the stone is lodged in the ureterovesicular junction, and you can see this dilation back up to the kidney, and you get this hydronephrosis. All right, another important equation for you to know. So this is how it's going to work. This is as far as I think they'll go for you guys. They'll give you that the oncotic and the hydrostatic pressures, and you'll have to figure out filtration fraction. And in the question, they'll also give you renal plasma flow, and they'll ask you what's the GFR. So the first step in that situation is you put it in the equation that I gave you guys, subtract the hydrostatics minus subtract the oncotics, and then you'll get filtration fraction, and then you'll move this over to the other side and you'll multiply, and then you'll get GFR. So two equations you'll have to use for that situation. But that's a good way of calculating GFR. Figure out the filtration fraction, they'll give you renal plasma flow, and you'll have to determine GFR. Okay, so some of the mechanisms the kidney is able to use to determine how much it wants to filter at the glomeruli is vasoconstriction and vasodilation. So this is from lecture. If you constrict the afferent arteriole, so blood is going this way, right? You can imagine if you constrict right here, you're decreasing all the blood along here. So you're going to basically decrease the renal blood flow, and you'll get a decreased GFR in this situation. But more importantly is this one. Let's say we get blood flow here, right? It's going across, and we constrict it at the very end. What's going to happen? Well, you're going to get an increased pressure right here, right? Because you constrict it at the efferent arteriole, which is going to cause you to have to filter more in the glomeruli, okay? So if the kidney wants to filter more to get rid of fluid, to get rid of the solutes, it's going to constrict the efferent arteriole. So what I would do, I would try to go through this slide and make sure you understand it in regards to this equation, right? Specifically the efferent. So if we constrict the end point, the efferent part, you're going to decrease plasma flow, increase the pressure. Therefore, you get an increased filtration fraction. If you constrict the afferent, you're decreasing both. So both the numerator and denominator go down. So technically you get no change. But they can ask you something about efferents versus afferents. Just remember, if we go back, if you constrict that end point, you know, it's a tube of fluid, right? And you constrict the end point, you're increasing the pressure behind it. So you're going to have to filter more. It's going to have to go through the glomeruli. Okay, so just keep that in mind. All right, so very simply put, Filtration is going to come from the glomeruli into the urinary space. Reabsorption is going to come from the urinary space back into the capillaries, typically the vas recta, right? And then if you're going to secrete something, it's going to go from the capillaries, say the vas recta, to the urinary space. And then whatever gets past that point is excreted. So you have this equation here. It's important to know this, but that's going to define what's excreted. So it's basically everything that's filtered, everything that's secreted, minus the stuff that's reabsorbed, and it goes through, right? And clinically, how this they could test you on this is some specific molecules are, for example, freely filtered, right? So inulin and mannitol are going to be examples of things that are filtered 100%. None of it's going to be reabsorbed back into the bloodstream. None of it's going to be secreted. It's just filtered. If you give somebody, and I don't think they do this clinically, they use creatinine, but if you give somebody inulin, and you would expect 100% of it to be peed out, right? You're not going to reabsorb anything once it hits the kidney because there's no tubular modification. It's completely filtered. Now, net reabsorption, we talked about this, particularly in the proximal convoluted tubule. You don't want to get rid of sugar. Like, you need sugar. That's the whole point, you know, is to have energy. So you want to keep your glucose. You want to keep amino acids, right? You don't want to be peeing all this stuff out. Now, this is important because for people with diabetes, that their blood sugar is so high that it overwhelms the proximal convoluted tubule. It overwhelms the system. So if you have glucose in your urine, that's typically the problem because your blood glucose is so high that you simply just can't reabsorb it all. Also, for example, if you have protein in your urine, you're not supposed to have that, right? That means there's a problem with the nephron. There's probably some renal failure that needs to be addressed. So you don't want protein, you don't want glucose. So all of it should be reabsorbed. Anything that gets through filtered, you better suck it back into the vas recta. Secretion and creatinine is the thing that they use to measurement. We don't go into too much detail now, but typically it should be 1. Anything above 1 can be indicative of a decreased GFR. So if GFR goes down, creatinine goes up. They're inversely proportional, but that's what they use to correlate to renal failure. So if we go back and you use, so if they give you a question like that, they'll usually it'll be straightforward. They'll be like UX equals this and B equals this. So it'll be straightforward. So you can use that when you do these equations and you could figure out the transportation, right? So make sure you understand the positive and negatives versus what we're talking about, right? Net reabsorption, net secretion. I put this in just for completeness sake. We kind of talked about these equations. I would make sure you know these. Again, they could ask you something to figure out filtration, give you the plasma flow, and you need to figure out GFR. And also make sure you know this equation. They could ask you this: the blood flow is the plasma flow over 1 minus the hematocrit. Now, you've learned these a number of times now. Facilitated diffusion is going to be when we talk about like the GLUT transporters. It's a facilitated diffusion. Active transport means you're pumping something against its concentration gradient. Okay, so keep these in mind when we go forward. So we kind of talked about this, but primary active transport is going to be like your sodium, potassium, ATPase, where secondary active transport is that glucose, that sodium glucose transporter. Now, we talked about this. Proximal convoluted tubules' major job is you're going to want to take in glucose and take in amino acids. Now, how do diuretics work? So if you remember that sodium is going to be tied in with water. So the vast majority of the diuretics work by either getting rid of sodium. So if you get rid of sodium, you're going to get rid of water and you're going to pee it out. It's a diuretic. It makes you pee. So more fluid in the urine. And by doing that, you're decreasing the blood volume. By decreasing the blood volume, you're decreasing the blood pressure. So these diuretics work like that. Water follows sodium. So that's kind of the idea there. But they'll give you a few drugs. You'll just need to know those thiazide diuretics. They typically have like chlorothiazide. They have thiazide at the end. There's some loop diuretics like furosemide and stuff like that. So you just want to make sure you know the names of those. Once you get to the loop of Henle, then we start talking about that countercurrent exchange, right? So, oh, look, right, there it is. There's calcium. So yeah, we kind of talked about that. So yeah, it's paracellular transport is the thing, and it goes with magnesium. That seems to ring a bell. I don't know. So I definitely know that up in this area, you can get paracellular transport. But when I think of calcium primarily, I think of the distal convoluted tubules. This is an important pump system, this sodium chloride potassium pump as well. So remember, the loop of Henle is going to be more when you start that countercurrent exchange. Distal convoluted tubule, I put this here because, you know, that's where we think of this, this calcium. Remember that PTH is going to increase your calcium and decrease your phosphates, and then vitamin D as well, right? It's all related to calcium. Now, the idea here is that if the body senses hypovolemia via a decreased GFR, it's going to do that via the macular density. So if there's decreased sodium being recognized, then there's decreased fluid, right? Because sodium and water go together. So what do? You're hypovolemic. You increase renin. You're going to tense down on the vessels. You're also going to release aldosterone. And the whole goal is to increase the GFR back to normal. So that's a mechanism that works. Conversely, the macular density recognizes too much sodium, which means there's too much water as well. You're hypervolemic. And then adenosine is a vasoconstrictor at the arterioles, afferent arterioles. So you try to bring the GFR back down to normal. So this is that balance that the body takes to have the mechanisms to regulate water. Now, the further along we get down the tubule, the more we're going to be worried about the water and also your pH. So when we talk about the principal cells, they have two methods. They use aldosterone and they use ADH. Remember, aldosterone is going to bring back sodium and kick out a potassium. In order to bring back the sodium, it has to kick out a potassium into the urine. That's important as a clinical marker. And ADH is going to put those pores into the principal cells, and that's going to allow water flow. Now, when you get down to the intercalated cells, we're going to be worried about the pH more. And what you see here is, so we can break this down. If we have increased aldosterone, right, we're going to be reabsorbing a lot of sodium, kicking out a lot of potassium. Well, that can be a problem if you're peeing out too much potassium. So these intercalated cells have a hydrogen potassium pump. So the aldosterone, if you have too much, is kicking out too much potassium. So the intercalated cells are going to try to bring back some of the potassium and sacrifice a hydrogen. Okay, so if you're peeing out a lot of hydrogens, you can get metabolic alkalosis. Okay, so I'll just say it one more time. Aldosterone is going to reabsorb sodium, kick out potassium. If you have too much potassium being kicked out in the urine, the intercalated cells are going to try to bring that potassium back into circulation and kick out a hydrogen. If you kick out too much hydrogen, you get this alkalosis, right? This increased pH. Okay, these are some of the hormones. Definitely want to commit these to memory. Make sure you know these. And then I put the drugs as well. So loop diuretics,
Explain ADH, please, again.
Yeah, sure. So ADH, what it does is it has these V2 receptors, and it basically puts pores, opens up pores in the principal cells, and that allows water to flow through. So ADH stands for anti-diuretic hormone. So it means you don't want to pee out fluid. You don't want to diurese. You want an anti-diuretic. You want to hold on to the fluid. So if you put pores in there, it's like this last ditch effort. It's like put the ADH, put the pore in. Let's bring back all the water we can right here before you pee it out. So that's the whole goal of ADH. So aldosterone brings back water in by primarily bringing in sodium, and ADH will make pores that will bring in the fluid.
Oh, Brady.
Is it in the, sorry.
What's
Hi.
that?
So in terms of aldosterone and ADH, they work in the same. What I'm getting is aldosterone takes care of the salt portion of it, and ADH takes care of the water portion of it, right?
So
No.
they both.
Okay, so they both do the same thing.
They both.
No.
They both. Okay. So
I'm just not.
no, it's all good. No, you're good. So they both bring back water. They just bring back water by two different mechanisms. Remember, water and salt go together. So aldosterone is going to say, let's just bring back salt. Okay, we'll bring back sodium. Bring back sodium, then water is going to follow. So that's how it's going to increase blood volume. ADH is going to increase water by putting pores in the tubule. And so water is going to go from the urinary system back into circulation. So they both want to bring back water. It's just two different mechanisms.
Okay, so aldosterone does it with sodium, whereas ADH does it with pores.
Exactly.
Yeah.
Yep.
Awesome,
Yep.
thank you.
So you can imagine with this sodium, potassium, you're bringing all this sodium, you're kicking out this potassium. There's much more side effects that can happen with aldosterone versus ADH, which just puts pores in. But we're going to get into that in a little bit when we talk about the deficiencies. So remember.
Sorry.
Yeah.
In lecture, the prof talked about alpha and beta intercalated cells. Should we know about that or?
Yeah, so if I remember correctly, they kind of work inversely. I don't think it's terribly important.
Alpha for protons, I think, and beta was for bicarbonate.
Yeah, maybe just know that. I think maybe that's the extent. Say that again?
Yeah, because it wasn't on the slide. She just said it, but then it came up in my group again, so I wasn't too sure if it was like worth knowing.
Yeah, maybe just that basic definition should be good. I doubt y'all even get questions about the intercalated cells, to be honest. But I just want to do this for completeness.
Okay, thank you.
Yeah. So some of the drugs we talked about these. Remember, diuretics. You want to get rid of fluid, decrease blood volume, decrease blood pressure. One we didn't talk about was acetazolamide. So it's a carbonic anhydrase inhibitor. So what it's going to want to do is kick out bicarb. Right. So if you have some sort of metabolic alkalosis, right, you have your pH is high. That means to get rid of the alkalosis, you kick out bicarb, right? By peeing out bicarb, you're going to bring the pH back down to normal. But we'll get into that in more detail. I just wanted to point out that that's the goal of acetazolamide. All right. I think this is one of Dr. Chapelia's. Is that how you say her name? Chapelia?
Hey Brady, I have a question.
No? Okay. Yeah, go ahead.
Do you mind describing the difference between the two diuretics, like the loop versus the thiazide ones, and how they work?
They're very similar. I don't think you really need to dive into the differences right now because they both work pretty much. Thiazides work more at the distal convoluted tubules. Loops work in the loop of Henle. So other than that, I think you should be good. The only side effect that you should be aware of is that thiazide diuretics will cause hypercalcemia. Okay, just because of the method. They could ask you that. I think I remember a question about that. But other than that, just know that where they work. Loops are in the loop, thiazides are in the distal convoluted tubule.
Okay, thank you. And I also had one more question. For the GFR, I know you were saying that we may not need to know like why it increases or decreases based on like physiological changes, but like on our slides, it has like a whole like list of like he wants us to know like what would like make the GFR increase or decrease based on physiological changes. And like a lot of our clicker questions from that lecture were based on that, but there was really no explanation as to how we really know that, if that makes sense.
What do you mean by like physiological changes? Like what, can you give me an example?
So for example, for like the nephrotic syndrome, like he said that the GFR would increase, but you know, he didn't really explain how we would know that. But I mean, he did say that, like you said, the oncotic pressure is going to increase, but he put a lot of questions like, okay, if someone had this, like would their GFR increase or decrease based on the oncotic versus the hydrostatic? So that was kind of confusing. And he also has like a page with like, know why these physiological changes like increase or decrease GFR.
Yeah, I mean, I just took from what he may have added these from last term. I used my notes from last term, so he may have added that. From my understanding, as long as you understand the basis between the hydrostatic and oncotic pressure, hopefully you can answer those sort of questions. But by all means, if he puts examples and stuff like that, yeah, I would probably go ahead and make sure, maybe not necessarily the whole physiology behind it, but just kind of the general idea that why, or just
Whether it
would
goes up
cause.
or go down. Okay.
Yeah, for sure. Yeah, I don't remember
thank
coming
you.
across that. So, okay, no problem.
Thank you.
Yep. So when we talk about body fluids, one of the easy questions they could ask is most of the fluid's going to be in the intracellular, right? Intracellularly, and 2/3 of it. And of the extracellular 1/3, 3/4 is going to be interstitial, 1/4 is plasma. So they could give you any of these and you could determine the other variable. Some of the equations, you do want to commit to memory that men are about 60% water, women about 50 to 55%. So just in case they give you a question about that, you can do the math on that. Also, we talked about this when the blood volume is the plasma volume over 1 over the hematocrit. So these are just other little equations that you want to be sure. For Dr. Chapaya's, I pretend that Chapaya and Mpadya had a baby. Chapaya, that's not their name either. That's it. Thank you. Yeah. So if those examples she puts in the lecture, yeah, I would know how to do those for sure. Like going through those, they're pretty straightforward, but I don't think they'll get any more complicated than that. This is how they could ask a question though. So you need to know that which of these correlate to which. So if they talk about this titrated water, you know that titrated water will help you determine your total body weight. So it disperses through intracellular, extracellular, all the fluids. Whereas mannitol, inulin, it's going to be primarily ECF. So what they can ask you is, what's the intracellular fluid? And then they'll give you 2 different variables, right? And so you can figure out what the other one is. I think she had questions regarding this. So just make sure if you know what goes with what, then the math works out pretty easily. And then obviously you can do that. You can use these concentrations, and that's how they do it in the question. They'll tell you you injected some of it, and then you can see how much was excreted. And by doing that, you can try to determine what the interstitial fluid or intercellular fluid is, depending on what compound they actually use. Okay, I know this is a little tricky. So for me, I don't really go too much into dividing the intracellular fluid and extracellular because it typically usually lands pretty close to the same. So this is how I do it. And if it works for you, then go for it. So remember, the y-axis is your osmolarity. So we're talking about the solutes, right? We're talking about sodium, everything that's in it. Remember, the x-axis is going to be water. So depending on what they ask you, you can try to determine what they're talking about. So for example, if it's hyperosmotic, right, you're adding a lot of solutes to the solution. So you would expect, for example, the y-axis to increase a lot, right? Now, if you increase sodium, you're obviously going to increase your volume. So if you do it this way, you can see that. Now, conversely, if it's hypoosmotic, you're drinking straight water, right? So if you do this, you're diluting what you have. So this y-axis is going to go down, and this x-axis is going to go up. So you're diluting what you have. For the test, I think it would be pretty straightforward. They'll tell you you gave some sort of hypoosmotic solution. Which graph is it, right? So you just need to determine if it's hypoosmotic, you're decreasing the ions or whatever, the solutes that are in there, and you're going to dilute it. So you're increasing the x-axis, okay? Now it works with volume contraction as well. If it's hyperosmotic, we're talking about you're going to increase your amount of solutes, and you're decreasing the fluid volume, right? Water deprivation, right? So that makes sense. So you are decreasing the amount of water, so your solution is becoming more concentrated. And so that's the way I do it. I know she went pretty quick through this, but for you guys, I think the questions will be pretty straightforward. You give some sort of hyperosmotic solution, and they'll ask you what graph it is. And this is kind of, if you could just, if worst comes to worst, just memorize it, right? So the osmolarity and the water, and it'll tell you what goes with what. So for example, like syndrome of inappropriate ADH. What does ADH do? It pulls back straight water, right? So you're basically diluting your blood, right, with water. So you can imagine that you're increasing the volume of water, but by diluting, you're decreasing your y-axis. So you're increasing the water, all the while you're decreasing the amount of solutes, right? So just kind of walk through these and do X and Y together, and you should be able to break those down. I just put
the adrenal insufficiency graph. I just don't understand why ICF would increase.
Yeah, see, she doesn't go into that in too much detail. So adrenal insufficiency, we're thinking like aldosterone problem, right? So we're going to decrease, and see, like she really just, like, as far as I understand it, I really just go off the graph of the y-axis and the x-axis. I'd have to sit here and think about it. So if we're decreasing the amount of sodium coming in, so we're contracting the ECF. Yeah, that's a good question. I'm not 100% sure. I can't tell you, but why the ICF would increase. Yeah, I'm not sure. Maybe it has to do with the potassium, that you're holding on to potassium.
It's probably like because you have low sodium reabsorption, you're becoming like a little bit hyposmolartic, and then you're going to have an increase of fluids going inside the cell.
Yeah. So yeah, and with that, so think about it this way. So the aldosterone is not going to work. I think this is how this works. So the aldosterone is not going to work. So you're going to pee out a lot of fluid, and you're going to pee out a lot of sodium. So remember that aldosterone pump has to do with potassium and sodium. So if you can't get aldosterone, you're going to be peeing out a lot of sodium and water, but at the same time, you're holding on to potassium. So by holding on to potassium, a lot of that fluid, remember when you did the graphs with the urea and everything that crosses over to see if it's hyperosmotic and hypoosmotic, if you have a lot of potassium, because you can't pee it out with no aldosterone, you're going to increase the fluid in your intracellular, you're going to increase the fluid in the intracellular compartment. Again, I think that's way more complex than you need to get into with this, as long as you can identify you're decreasing y-axis, you're decreasing your solutes, and your overall what you're doing with the water content. But I think that's why you increase the ICF, is because of the potassium that's still left over, because aldosterone's not working. You're probably hyperkalemic, actually. These patients are probably hyperkalemic just because they can't pee out the potassium. All right, let's see. I'll put this in here for completeness.
Brady, sorry. Do you think it's like sufficient enough to just memorize like what the graphs look like and the like diseases or whatever is happening related to it, and call it a day?
Yeah, I honestly do. I mean, I think the few questions we had on there were straightforward. There might have been one where I think there was one where you gave like dextrose, and it was hyperosmotic, and it was just like, okay, well, you're decreasing the y-axis and you're increasing the x-axis. There you go. So like, that's why I don't try to dive into the intracellular, extracellular compartments too much, because you can make your head spin, and you only have so much time on the test.
Sorry, you said dextrose is what, hyperosmotic contraction or expansion?
Expansion. If you give dextrose fluids, that would be a hyperosmotic expansion.
Thank you
so yeah, the dextrose is just for sugar in case they are in case they're hypoglycemic. But yeah, overall, it is a hypoosmotic solution. Okay. But honestly, look, well, no, that's because they have the saline. Yeah, if it's just dextrose, it's hypotonic. Here it is right here. Yeah. Obviously, 0.9 saline is isotonic. So you would, if you give isotonic solution, you would expect an increase in the y-axis, increase in the sodium or the solutes, and you get an increase in the x-axis as well, which is typically what you want for a patient.
Brady,
all right. Yep.
Hey, I had a quick question. I was doing one of the Modo questions, and they explained that, not explained, but in the question vignette, there was a part where they put in a solution that we didn't talk about. So I'm just wondering, like, are you responsible to know what kind of solutions
No,
or what
no,
osmolar?
no. They should. If even if they give you a solution, they'll tell you what are the characteristics of it. Like it's hypo or hypoosmotic. Like even this, I think, is more detailed than what you need to know. But I wanted to put it just in case.
Sounds great. Thank you.
Yeah. Okay, so these are the formulas you need to know. If you break it down, it's pretty straightforward, not too much. Now, serum proteins, I think this was Dr. Trott's lecture. This one's not bad. So remember that you have these different peaks correlating to the different serum proteins. So albumin's going to be the big one, and then you have these as well. You need to memorize these, know which go with which. And if you do that, you'll be able to tell. I have a summary slide that has everything you really need to know. So remember, we talked about this. If you have hypoalbuminemia, remember albumin stays in the vessel. So you have a decreased oncotic pressure in the vessel. So you have a decreased pull in the vessel. So you're going to have more fluid in the interstitial compartment, right? You don't have the pull to pull fluid into the capillaries. So it's going to stay in the interstitial fluid. So you can see that here. So one of the major points of albumin as in the capillaries or in the vessels is for that oncotic pressure to hold fluid into the capillaries. All right. So remember, if you have this decreased oncotic pressure, you can end up with edema and ascites. And look at this little girl. Like she's losing albumin because of this, because it's going through the basement membrane. And look how puffy she is. That's because all that oncotic pressure is lost. So a lot of fluids building up in the interstitium. Okay, so we mentioned this briefly in the pulmonary part. Remember, so neutrophils are going to make elastase. Elastase, being an enzyme, is going to break down elastin. So it's alpha-1 antitrypsin's job to help counteract these neutrophils and the elastase. So I think this was from Dr. Sobring's lecture. It's a serine protease inhibitor, just in case he asks. That's how it works. And remember that there's different isoforms of it. The ZZ isoform is going to be the homozygous mutant allele. So that's going to be the really bad one. So remember, people that have this are prone to getting emphysema. So you can see specifically if they smoke, it's kind of like a two-hit effect, right? You're getting the emphysema from the both the tobacco and the fact that you have decreased alpha-1 antitrypsin. Right, so this is the point. I put a star on this. I remember a question on this. It was tricky, and this is the point. There's alpha-1 antitrypsin has two effects, and genetically, they're opposite of each other. So you have a loss of function mutation in the lungs, right? You're losing the protection from elastase, but you also have a gain of function, gain of anomalic function in the liver, and that's going to cause this hepatocyte damage and cirrhosis. So he could ask you, I think it's when he asked us, it was tricky. He asked us whether which one was like what was the liver pathology, and it was the development of a novel function, right? And you wouldn't think hepatocyte damage is, but that's just what the rules are. So remember that you not only if in this genetic scenario do you get a loss of function, but you also get a gain of function too, depending on whether it's the lung or the liver. Alpha-fetoprotein, remember that is going to be a marker for neural tube defects. It also is a marker for hepatocellular carcinoma. But for now, you just need to know that it falls in the alpha-1 globulin category, and it is a marker for neural tube defects. You can see spina bifida here. So if you get high AFP, I just kind of remember the spina bifida, it's almost like the alpha-fetoprotein spills into the amniotic fluid. That's just kind of how I remember it. And that's why you get high AFP in the for neural tube defects. And classically, you get low alpha-fetoprotein with Down syndrome. Okay, so keep that in mind. Those are opposite of each other. Wilson's disease, I'm not positive y'all went into this in too much detail. Is this the first time this is the first lecture y'all talked about this?
I think
Yeah.
so.
Yeah, I think so.
Okay,
Yeah.
maybe next term, y'all. I can't keep all that straight. Next term, y'all get into this. So the idea of Wilson's disease is you have copper accumulation. You get these things that are called Kaiser-Fischer rings, and that's actually copper accumulation around here. But for right now, you just need to know that it's a problem with this transportation. And if you don't have this, you can't make ceruloplasmin, okay? And that's gonna be one of the markers that we're gonna look at. So remember that that's one of the markers, and if you can't make that, you end up with Wilson's disease. Now, this last segment here are going to be your immunoglobulins. So the plasma cells are going to make immunoglobulins. So that's what's going to fall there. Also, multiple myeloma is a form of cancer, and they get what's called a monoclonal gammopathy, right? So it'll just be like IgA or IgG. It's monoclonal, and you'll get this huge spike. So if they give you a graph like this, this is indicative of multiple myeloma if it's monoclonal. I forget who did this lecture, if it was Dr. Mpadi or not, but she does or Dr. Trotz, but these acute phase reactants, these happen when you have some sort of insult to the body, some sort of infection, burn injury, stuff like that. These are going to be made, the green ones are going to be made in higher priority because they help with fighting off the infection. These are going to be downregulated, the ones in red, so that you can make more of the green ones. Keep in mind that C-reactive protein is the primary protein that's released in an acute phase reaction, but it doesn't fall under this category. So if you get an increased C-reactive protein, it's indicative of some sort of infection, and these are going to be some that are upregulated versus these that are downregulated. This is the super important slide, so we can break this down. Remember, an acute inflammation, you're going to get this alpha-2 spike, and that kind of correlates to these here. Some of these are alpha-2s. So the first thing you need to do is break them down and see like which fall into which category, and then you can do this. Prolonged inflammation, obviously you're going to get a lot of gamma globulins there, right? You're going to get a lot of inflammation cell, inflammatory IgA immunoglobulins because of their gamma spikes. Liver cirrhosis, so remember, if you have liver cirrhosis or liver failure, you're going to make decreased albumin, and this is called the gamma bridge. It's just, I believe it's IgA, you get an abundance of IgA and it makes like this bridge formation. But just remember, in liver cirrhosis, you get decreased albumin and this little bridge formation. We talked about multiple myeloma. Remember that there's albumin's normal, but you're going to get this monoclonal spike. So you get a drastic increase in IgG, for example, and that's going to give you that. Nephrotic syndrome, decreased albumin, and you have an alpha-2 spike. Hypogammaglobulinemia, obviously you're not making gamma globulins, and alpha-1 antitrypsin, that's falls under the alpha-1 category, right? So if you're not making that, you're not making, you're going to see this formation. So once you just line them up in your head, they'll make sense. I believe this is the spike, this alpha-2 spike is because of ceruloplasmin, but you'll have to double check that one.
No, that one is alpha-2 macroglobin, I think.
Thank you.
Because
yeah,
of the 20th fold.
Yeah. Okay, yeah, thank you very much. Yeah, so just remember to keep these separate. This liver cirrhosis is going to cause this gamma bridge, and this macroglobulin spike is going to be for nephrotic syndrome, but both are going to cause decreased albumin. Thank you. Okay, so we kind of addressed this whole idea that sodium is going to correlate to ECF volume, specifically ECF volume, right? Because most of the sodium is in the ECF compartment. So that's what we're going to regulate. Now, the regulatory mechanisms we're going to use, which we've talked about most of them, the RAAS system is going to sense hypotension. The renal nerves are going to be your sympathetic modulators, right? So it's going to constrict with, say, angiotensin. And ANP kind of works, it works opposite of the RAAS system. So whereas RAAS will detect hypotension, ANP will stimulate or it's going to recognize hypertension, right? And it's released from the heart. So if you get hypertension or hypervolemia, it's going to correlate to trying to get rid of excess fluid. So, right, the volume sensors, right, you have baroreceptors that are going to help regulate and help recognize low blood pressure. The Starling's forces are going to come into play as well if there's a lot of hydrostatic pressure that's involved. and then the macular density is going to regulate sodium. So all these come together, and they can help with that RAAS system to help regulate the idea of getting rid of blood volume, or excuse me, or increasing your blood volume, because these are activated by a decreased blood volume. So again, this is more of the same. We're going to activate it. I have it here broken down. So when we activate angiotensin 2, it's going to tense down on the vessels. We secrete aldosterone. Aldosterone is going to increase our sodium reabsorption, which is going to increase water reabsorption. ADH is going to put those pores in towards the collecting tubules and the distal convoluted tubule, and it's going to help with water retention. So the whole goal here is to increase blood volume, increasing your blood pressure. This is from first aid. I thought it kind of laid everything down. There's those alpha cells. It doesn't look like they talked about the beta cells, but that's there. Yeah, baroreceptors. One of the tricky things about this is a decreased baroreceptor firing is going to correlate to an increased sympathetic tone. You would think increase would go with increase, but if you just remember that a decreased blood pressure will cause a decrease in firing, and by decreasing the firing, it's going to increase tone. And you know, it's just one of those things you have to memorize, that it's opposite. We talked about this. This is more about the Starling's forces, this flux, this pressure. Are we filtering? Are we reabsorbing? So obviously, if you have a lot of volume involved, you're going to be filtering a lot of fluid, a lot of hydrostatic pressure, versus if you have a lot of oncotic pressure, whether it be in the capillaries or the interstitial fluid, will determine which way you're going to go. And I put this one more time. So this is going to be super important. So whichever way works for you, but this is just the one I like to use to figure out the filtration. This is again from first aid. It kind of just outlines everything. So we see the glomerulus, this tuft of capillaries, this afferent arteriole coming in. We have the macula densa here. It's going to regulate or be the osmoregulator. You have the JGA cells, which are going to help release renin. So you're going to bring the fluid in. You're going to filter it here. You have the oncotic pressure pulling. You have the hydrostatic pressure pulling. You also have the hydrostatic pressure from Bowman's space pushing, and the oncotic pressure from Bowman's space pulling. Then you can see everything that's filtered, everything that's reabsorbed, secreted, and excreted. So if you sit down and just kind of walk through these different aspects, it kind of lays everything out for you. Okay, we talked about A and P. So remember, it's gonna sense hypertension. So its whole goal is to tell the kidney to pee out more water. By peeing sodium, you're gonna pee more water. This is the summary slide I put in here instead of going into detail with, I think it was the solute handling. I think Dr. her name. I'm sorry, I can't remember it. Chilapilla, that's it. This is the summary slide because it kind of breaks down what goes with what, right? So sugar, amino acids, and sodium in the proximal convoluted tubule, and the system of countercurrent exchange in the loop. And you're going to worry about calcium once you get to the distal convoluted tubule at PTH. And then again, you're going to be regulated with aldosterone and ADH to where the collecting tubule and collecting duct to reabsorb or excrete water. The whole thing about the countercurrent exchange, you don't need to dive too deeply into this. It's just the idea that if there was equal amounts of everything on both sides, then nothing would happen, right? You would just get a normal flow. So the whole principle here is that by having this opposite effect, you're able to get rid of water or get rid of or retain salt and chloride until you get to the right osmolarity to where you want to pee it out. So that's the whole principle there. And it is important that urea is a major player. By putting urea back into the urinary system, you're able to help use that as a variable to bring water in. So urea is going to be one of those molecules that helps to pull water back into the urinary system. Okay, So diabetes insipidus, there's two different types. These are super important. I'm sure you'll have a question like this on the test. So central means you're not making ADH. You're not secreting it from the pituitary. If you have nephrogenic, you have adequate ADH. It's just the receptors won't respond to it. So those show up differently when you look at this. So what do they do when they expect a patient has DI? They actually just give them ADH. So remember, central isn't going to, they're not making it. So if you give them exogenous ADH, they're going to respond to it. Whereas nephrogenic diabetes insipidus, they have enough ADH. It's just that the receptors aren't going to respond. So nothing's going to happen. But this is urine osmolarity. So you see here, if you give these patients with central diabetes insipidus ADH, you're going to help, that's going to help to bring water back into the system. So their urine's going to become more concentrated. Okay, so that's what they're getting at here.
Brady, I had a quick question about the polydipsic because I struggled with the polydipsic slide, the curve. Is because they're saying that polydipsic is like they said it was a psychological condition. Does that have anything to do with the receptors though? Because in the follow-up chart that she had, she said that ADH was low in those in people with it. So I'm not I wasn't too sure what was on the graph.
Yeah, I think I don't know that this is the really important part that you need to focus on. I think the idea here is that you're trying to not give, or you're not giving them any fluids to drink. But the major point you want to get at here is the effect once you actually give them ADH. I don't really know what they're trying to get at here, but it's not, I don't think it's clinically important.
Yeah, I think they're using it as a control group because I think it's just to assume that they have normal ADH, but I'm not sure actually.
Yeah, the thing with the thing with polydicystic is that your brain doesn't tell you that. You think you're thirsty all the time. That's what your brain telling you. That's it.
Yeah. Yeah.
Okay, so yeah, that makes sense that it would be a control. Yeah, but in regards to the DI, I don't think that's too relevant. Yeah, so, and that kind of goes into the differences there. But if you could differentiate these, you'll get a question or two, right? Whether, you give them exogenous ADH, whether it will affect it or not. And you can go through this slide. It's a very good slide to try to differentiate what's going on. Do you have ADH? Do you not? Are you secreting too much ADH? And make sure you differentiate. Remember, plasma osmolarity is going to be how much solutes or sodium and whatnot you have in the plasma versus urine osmolarity, same thing, and the volume. So remember, free water clearance is going to be all the water that goes excess of the actual concentration. So if you have a high free water clearance, you're peeing out a lot of just pure water. And these are some of the formulas. These will probably be straightforward if they even do give you a formula like this. They'll give you these and you'll just need to plug it in straightforward. And it is important to understand, like I said, that this free water, if it's positive, you're getting rid of a lot of free water, right? And if it's negative, you're getting rid of a lot of concentrated urine. Okay, so this is a little tricky and seems a bit convoluted, but this is the way I break it down. So remember that everything down here is stuff you want to keep or reabsorb, and everything up here you want to secrete or you want to excrete. So stuff like PAH, creatinine, you're going to get rid of a lot of it. Inulin, remember, inulin's freely filtered. Creatinine is secreted. But look here. Right at the proximal convoluted tubule, you remember we talked about the whole goal. You want to bring all that glucose, bring all those amino acids back in. So this is how I break it down, and I try to remember. If I just wrap my head around what parts I'm bringing in and what I'm trying to get rid of, I could kind of guide myself through this. And we talked about this. This is why these are going to be highly excreted in the urine, right? That's why they're up here on the top of the graph. They do show you this one as well. So this is just specific for the proximal tubule, but it works the same, right? You're going to put creatinine in the urine, whereas you want to keep glucose and amino acids. Bicarb is one of those things typically you try to keep unless we get to some sort of alkalosis, acidosis problem, which we'll get to in a second. This is just another summary slide. It kind of breaks down the math behind what's going on with filtration, reabsorption, secretion, and excretion. But you can plug these in and figure those out. And then this is just some more formulas you need to know just to be sure, you know, you get these questions right on the exam. All right, so this is the most important stuff. Lindsey and I were talking about this earlier. There's probably 30 questions on the exam that were just straight up figure this out. pH, which one, you know, respiratory acidosis, alkalosis, and stuff
Brady,
like that.
we have a request to take a couple-minute break.
Amen.
Before acid bases.
Sounds good to me. We'll come back in 5 minutes. Perfect. So there, I know y'all haven't really gotten to, y'all briefly touched on the acid base, the idea of the acid base stuff, but the questions are primarily going to come from what y'all do tomorrow or before the test. But there is a method to doing this, and if you follow the method, you should get all these right. It's pretty straightforward. But by all means, do as many practice questions you could find on this, because, like we said, it's highly tested.
Brady, how heavy was renal by comparison to like the other stuff on the exam? Just because, I mean, that's been giving a lot of us problems with the like random transporters and stuff.
Like compared to pulmonary?
Compared to like pulmonary and acid base.
Oh, well, I guess I would, I've kind of put acid base with renal. I mean, I thought it was fairly straightforward. Like, I remember thinking like, this is really complicated. And it's like, we didn't really get taught like to understand this complicated material. So I think it'll be easier than, well, I'm hoping it'll be easier than you anticipate. It's hard to say. I think by all means, when I finished the test, I was like, thank God I knew how to do the acid base problems, because that was just a huge component of it. I also remember thinking that there wasn't a lot of tricky math problems on there. Now, granted, your test is going to be different than ours, but I do remember that that there wasn't a lot of crazy math on there. But as for the transporters and stuff, it's hard to say. You know, if you're going by high yield stuff, make sure you know the clinical aspects, because all the questions have to be written in a clinical format. So you could take it from there. Okay, so y'all, I believe y'all touched on this Friday. So the whole idea, remember that the whether it's charged or uncharged in the stomach versus the intestines, remember that if it's not charged, that's going to be more lipophilic and it's going to be absorbed in. So for acids, they'll be absorbed in the stomach. For bases, they'll be absorbed in the intestine. So it depends whether it's an acidic environment or a basic environment. Buffers are used in the body, primarily bicarbonate, which is going to be the major buffer. But you know, you don't really need to know too much about that. That was more of FTM stuff. So the idea that I think I might have put it, yeah, that's one thing you do need to know, that this bicarbonate ratio was 20:1. I do remember them asking something about that. But that's the bicarbonate buffer system in the body. So I couldn't remember, Lindsey, did we do this in term 2 or was this term 1, this stuff? Was this,
It was both.
Have y'all seen this before?
Yeah, we saw in pharmacology.
Yeah.
Okay, good. So yeah, remember that this correlates to a 10:1 ratio. So that correlates to 1 unit above. The way I do these, just in case they put it on there, if it's an acid in the stomach, it's primarily going to be absorbed. So you're in the 90 range. If it's a base in the stomach, it's not going to be absorbed. So you're down here in this range, because this can get confusing. And if you do it this way, that's fine. I just find it easier that if you know where it's absorbed, you're in the 90 range. So just remember that'll correlate to a number, and you can keep that in mind. Okay, so whereas the absorption of the drug, it needs to be lipophilic, When you excrete the drug from the kidney, it needs to be charged. So it's exactly the opposite. So when you excrete these compounds, you want it to be charged, whether it be an acid or a base, but you need to, a lot of times, once it goes to those P450, those liver enzymes, it'll make it charged. So therefore, you'll be able to ionize it and excrete it. Okay, again, this is just more about the bicarbonate buffer system, but that's going to come into play when we do more of the problems. Okay, so remember that when we talk about respiratory problems, the primary problem is going to be with breathing, right? That's going to be the primary insult. So when we have respiratory acidosis, let me say this first. This is the most important thing. This saved the day. Treat carbon dioxide as an acid, okay? So if you're hyperventilating, you're getting rid of acid, right? You're breathing out carbon dioxide. So you're going to get respiratory alkalosis. If you're hypoventilating, you're holding on to carbon dioxide. So you're going to get respiratory acidosis, okay? So if you keep in mind that carbon dioxide is treated as an acid, then it'll make this that much easier. So yeah, so when you have some sort of respiratory problem, you have a compensatory mechanism, and that's going to be in the kidneys. So if you have respiratory acidosis, the compensatory mechanism is going to be metabolic alkalosis. You have too much, because of the respiratory problem, you have too much acid. So the kidneys are going to compensate by holding on to base, right, to try to even it out. So keep in mind that that takes days. So if you have a respiratory issue, the kidney compensation takes days. Conversely, if you have a kidney problem or a metabolic problem, better said, the respiratory compensation is immediate, right? You just change your breathing rate. So remember, the only two ways you can compensate is by breathing faster or slower, or by peeing out more acid or more base. So that's the whole idea here. So one of the things, if you have respiratory acidosis, how do you compensate? Well, you pee out acid, right? You have too much acid in your blood because you're the respiratory problem. So respiratory acidosis means you're hypoventilating, right? You're holding on to carbon dioxide, so you get respiratory acidosis. So what's the kidney going to do? You're going to pee out acid, right? You're going to cause metabolic alkalosis, right? Because if you pee acid, metabolic alkalosis. This will be clearer once we do some equations. But just remember, if you have respiratory acidosis, the goal of the kidney is going to pee out acid, right? To counteract it. Okay, so some of the things, obviously, that if you're going to want to increase acid secretion or to pee it out, these are going to be the problems. So we talked about this respiratory acidosis. You want to compensate by peeing out acid. Decrease pH, again, acidosis, you're trying to get rid of it. Hypokalemia is one of those tricky ones. Remember that, like with aldosterone, when you keep sodium in to keep water in, you're kicking out potassium. But in the tubules, what happens is to bring this potassium back in, you have to exchange it for a hydrogen. So that's going to be a situation where you're going to get rid of a lot of hydrogen. You're going to excrete hydrogen, and you're going to get this metabolic alkalosis as compensation. So here's the clinical aspect, this Cohen syndrome. So it's primary hyperaldosteronism, which means the primary problem originates in the kidneys. So there's going to be too much aldosterone, so you're going to get hypertension. Why is that? That's because you're bringing in a lot of sodium, so you're bringing in a lot of water. Now, you're also going to have, because you're bringing in sodium, you're getting rid of potassium, right? So you're going to get hypokalemia. And then this renal tubular absorption of the hydrogen ATPase, because your body's going to want to bring some of that potassium in later on in the tubule, you're going to have to kick out hydrogen, okay? So it's kind of walk down the tubule here. You're bringing in sodium, you're kicking out potassium. You want to bring potassium back, you got to kick out hydrogen. You kick out hydrogen, you get alkalosis, okay? This is just a breakdown. This is tricky, so try to pay attention in lecture when she talks about this, because you do get this paradoxic aciduria. And the problem is that when you have metabolic alkalosis, or you get volume contraction, the whole goal is aldosterone is going to be stimulated to bring back in fluids. And by doing that, you're going to get hypokalemia. Now, as we said before, the tubules are going to try to bring back in the potassium. Therefore, it's going to kick out the acid, the hydrogen acid. So Dr. Mpagi is going to go into this in more detail, but just remember in this metabolic alkalosis situation, respiratory acidosis, you wouldn't think you'd be, respiratory alkalosis, you wouldn't think you would be peeing out a lot of acid, right? But that's just because you have to reabsorb the potassium. All right, and then the diuretics. The one thing I wanted to point out here is one of the major side effects of these thiazide diuretics is hypercalcemia. Okay, so we already talked about the renal compensation, this mechanism that it takes time. If you have respiratory alkalosis, you're going to try to get rid of bicarb, right, to even it out, and vice versa as well. Now, yeah, I said, I'm sorry. And for acidosis, if you have respiratory acidosis, you're going to try to pee out more acid so you can compensate. So I think y'all saw most of that already. I want to try to do some of the problems that correlate to it because that's what they're going to do in the test. Remember this Davenport graph? I put it here. Have y'all seen this yet? Or is this next week?
Not yet.
Okay, great. She's going to go into this, but based on the pH and the plasma CO2 and the carbon dioxide, you can just basically remember what falls in what. So they can give you either a graph and show you a point here, but if you just memorize the different quadrants, then you know where you sit. Or they can give you a situation when then they ask you on the diagram where everything fits. But you could do it based on this, or you could just memorize it. But this is the breakdown, if you like these sort of flow graphs. And then this is from first aid. So you get this compensatory mechanism. So remember, if there's some sort of renal compensation, it's going to be chronic because classically, if you have respiratory problems and the kidneys have to compensate, it takes time. Time means it's chronic. Okay, and then we get into respiratory acidosis. So remember, the idea is since carbon dioxide is treated as an acid, respiratory acidosis means you're holding on to carbon dioxide. And if you're holding on to carbon dioxide, that's going to make you acidic, respiratory acidosis. We did say there is compensation by the kidneys. So if you have respiratory acidosis, to compensate, you want to increase your bicarb in the kidneys or pee out acid, right? The whole goal is to increase the alkalosis to counteract the acidosis. And then these are some of the problems that could cause hypoventilation or increased carbon dioxide, specifically drugs like opioids that'll cause respiratory depression. If that's the case, you can get metabolic acidosis. So if it's alkalosis, that means you're hyperventilating, right? So you're gonna be breathing out a lot of carbon dioxide. That's why when you get anxiety attacks, you can actually breathe into a paper bag. You're breathing in your carbon dioxide, and that helps to calm people down because you're not going to get this alkalosis symptoms or this alkalotic symptoms. So in a chronic respiratory alkalosis, remember, then the kidneys will have time to compensate. Yeah, we mentioned this before. This is that hyperventilation anxiety that forms. Metabolic acidosis means you're peeing out too much bicarb or you're holding on to too much acid, right? So the compensatory mechanism here is going to be immediate, right? Because all you have to do is change your ventilation pattern and you can compensate. So you're not worried about acute or chronic in this situation. You're just going to try to compensate immediately with this metabolic insult. Now, it is important to know that even though you have a metabolic problem and you're going to get compensation by the respiratory system, if over time you can actually get a metabolic compensation as well. And again, that's going to be like getting rid of acid or getting rid of base. Diabetic ketoacidosis is a classic question they could ask. These people with type 1 diabetes can come in and they have metabolic acidosis. So how would you expect them to be breathing? If they have metabolic acidosis, to compensate, you want respiratory alkalosis, which means they would be hyperventilating, right? Because they're going to be breathing out more carbon dioxide, which acts as an acid. For these, you really just have to go through the problems and they kind of work themselves out. Remember that the ANI and GAP is a measurement of stuff or it's the unmeasurable anions. So this equation, as long as you know this, you should be able to calculate it. It should be straightforward. And then when we get to, there's either two ways to get metabolic acidosis. Either you're keeping acids or you're getting rid of bases. So some of the classic problems that cause increased acid are the DKA, lactic acidosis, or even chronic renal failure. Now, if you're getting rid of too much base, the question they'll probably use on the test is diarrhea. If you have diarrhea, you lose a lot of bicarb. So if you're losing bicarb, you're going to get acidosis. Metabolic alkalosis means you're either keeping too much base or you're getting rid of too much acid. So the compensatory mechanism is going to be to hypoventilate. Yeah, and again, remember, even though the primary insult is metabolic, over time you still can get compensation by the kidneys. Metabolic alkalosis, again, something like vomiting, that's the one they like to use. Obviously, if you're throwing up acid, you could get an alkalosis because you're getting rid of too much acid. Mixed disorders is one of those tricky ones. They could ask you about this, and that just means they're both going in the same direction, right? So it's a combination of things. So if you ever see that the carbon dioxide and the bicarb move in, they move in opposite direction, that means that it's mixed. They're supposed to move in the same direction, which you'll see when you do the problem. So if they go in opposite directions, you're getting a mixed insult. You're getting acidosis by both for whatever reason, or alkalosis by both. And there are some problems that you can know that does it, specifically aspirin poisoning. You can get a respiratory problem along with the metabolic acidosis as well, or alkalosis with the respiratory acid, with the metabolic acidosis. Okay, so this is the main point you need to pay attention to. So first, what you need to do is you need to determine the pH, right? Look at the pH and determine, are you in acidosis or are you in alkalosis? Cool, that's easy. Then you want to ask, what's the primary problem, right? What's causing either this acidosis or alkalosis? Once you determine that, then you know what the primary problem is. So you can go through your differential of what the problem is caused by. And then lastly, you want to ask yourself, well, is it chronic or not? Is there compensation by the other mechanism? So if there's a respiratory problem, are the kidneys compensating, and vice versa? Again, I'll put this diagram, y'all will go through it, but if you memorize these, you'll be good for the test. This is just one of those flow diagrams, so if you like these, it breaks everything down for you. Normal levels, they may give you them on the test, but if you remember that, pH is about 7.4, PCO2 is about 40, and bicarb's about 25. If you remember those, you'll get through these a lot faster. Okay, so I'm gonna do 2 practice problems with you guys, and then Lindsey's gonna take over and do some questions. Okay, so this patient has cystic fibrosis. The sputum's green. She's wheezing. So what's going on? Okay, so our first question is, what's our pH? Normal 7.4. So 7.3 is the pH. So we know we're in acidosis. So then we need to ask ourselves, well, what is causing this acidosis? Is it respiratory or is it metabolic? Well, this patient is actually hypoventilating, right? By hypoventilating, you're holding on to carbon dioxide. Carbon dioxide acts as an acid, so that's why that's increased. So that's the problem. And then, right, so treat carbon dioxide as an acid. The patient's hypoventilating, so you get respiratory acidosis. Then lastly, you want to ask yourself, is there compensation? Has there been time to where the kidneys are able to compensate? We know it's about 25 and 24. It falls in the normal range, so there is no compensation. So it's acute. So that's kind of the methodology you use when doing these. So let's try this one. This guy's been vomiting, so right away you should key in on he's throwing up acid, right? Yep.
Brady, can I ask you a question on the last one?
Yeah, sure.
Just so I can clarify. So what would happen if there was compensation to the bicarb? It would go up, causing metabolic alkalosis?
Yeah, it would try to compensate by causing metabolic alkalosis. And the whole goal would be to try to counteract this respiratory acidosis, to bring the body back to equilibrium. It never actually gets to equilibrium, but it always pushes the point to where it's trying to get there. But yes, so the compensatory mechanism is going to go opposite of what the insult is. And the next problem has the compensation that we can look at. Okay, so vomiting, you're thinking maybe losing acid, but let's look at the values here. Pyloric obstruction, so yeah, he's probably getting rid of acid. So what are we saying? Okay, so 7.56, normal 7.4. We know we're in alkalosis. So now we need to ask ourselves, what is, oops, I should have changed this to alkalosis. What is causing the alkalosis, right? Is it a respiratory problem or is it a metabolic problem? Well, alkalosis, remember, this bicarb is elevated, right? And bicarb is a base, so that's causing the alkalosis. So you know that the problem is metabolic alkalosis, right? Then you want to ask yourself, is there compensation? So the compensation should be opposite of the metabolic alkalosis. And it is, right? Because you're hypoventilating, holding on to carbon dioxide. And by doing that, you're trying to cause respiratory acidosis, right? To compensate. So metabolic alkalosis here, this correlates with alkalosis. So we know it's metabolic. And then yes, there is compensation, which you would expect because you can just change your ventilation quickly and you would expect that compensation and immediate response. Okay, and just one more thing. When you do have this metabolic alkalosis or acidosis, you do get this immediate respiratory compensation, but you do get a renal compensation as well. It just takes a little bit of time. Okay, we'll do some
sorry,
questions.
can you go over that all over again? I'm so lost to where
Okay, no worries. Yeah. Okay.
This one, slides, but what you're saying is not clicking to what it says on the slides to me.
Yeah, and I'm just also kind of confused because it says the normal ranges are 33 to 45. So where did like how do we know like we're using like 40 or I don't know?
Oh,
I'm confused.
Okay, wait. Okay, hold on. Okay, so this one, right? Not the first one or this one?
Both of them, to be honest.
Okay, that's fine. No worries. We're good. Okay, so yeah, I put, when I put the number next to it, that's just the, you really need to know the normal ranges here. Yeah, 33 to 45 and 22 to 28. So anything outside of those ranges is going to classify it. Okay, so pH is down, right? So we have acidosis, right? So now we want to ask ourselves, do we have respiratory acidosis or do we have metabolic acidosis? So when we look at these values, the PCO2 is elevated. Does that cause acidosis? Yes, it does, because carbon dioxide is an acid. It acts as an acid. So this is going to cause the acidosis. Right here, the bicarb is in the normal range. So it's not causing the acidosis. So we know that the primary cause of this acidosis is respiratory. Now the last, what's up?
So to differentiate between the respiratory, so respiratory would be the PCO2, and then if it was the HCO3, then it would be the metabolic?
Yes, exactly. Yeah, because you regulate your CO2 by your breathing, and you regulate your bicarb by peeing it out metabolically, right?
When you do these questions, I highly, highly, highly recommend using a flow chart, and I recommend copying a flow chart. So you're writing it down and you can like do that. Yeah. Because step one is what is the pH? And then step two, it's acidosis. It's okay, respiratory versus metabolic. And you kind of have to think to yourself, okay, if I'm in an acidosis, which you already know from the pH, like that has been established, what factor would cause a metabolic acidosis versus a respiratory acidosis? And then you look at the numbers. So first you have to know, what am I expecting to see in an acidosis? And then you have to look at the numbers. Okay, is my PCO2 elevated? If it is, okay, then it is a respiratory acidosis. But if it's not elevated, okay, then it probably isn't respiratory. Then you look at the HCO3. Oh, that is low. So yeah, that probably is a metabolic acidosis. That's kind of the stepwise way you need to think about these things. But when you're practicing these for the first time, you do need a flow chart to do it.
Yeah. Yeah, I should have pointed that out. So when you talk about PCO2, that's carbon dioxide that you're breathing. So that variable is going to correlate directly to respiratory acidosis or alkalosis. Your bicarb is going to correlate directly to your metabolic acidosis or alkalosis. Okay, so we know we have acidosis. So then we ask ourselves, which variable is causing the acidosis? So then we look at these. PCO2 being elevated does cause respiratory acidosis. Since the normal value is 40 and we're at 50, that means you're holding on to carbon dioxide, and that's an acid problem. So you get respiratory acidosis. So that's these two, right? So now, is there compensation here? 24 falls in the normal range. So if this happens over time, this respiratory acidosis, there will be compensation by the kidneys, but it just hasn't been long enough. So we can say that this is an acute problem because there's no compensation. Okay, and look, this is just introductory for you guys because y'all haven't had the lecture yet. Once Dr. Mpadje goes through it, then it'll be much easier. So let's take a look at this one. Okay, so step one, are we in acidosis or alkalosis? Right, alkalosis, right? Now you're going to ask yourself, is it a respiratory cause or a metabolic cause? The PCO2 being 50 is acidosis, right? Because you're holding on to carbon dioxide. That's an acid problem. So that can't be why. But if we hold on to base, if we hold on to this metabolically, that will cause alkalosis, right? So this is our problem. We have a metabolic problem. I need to change this. I will. It should say alkalosis. So this is a metabolic problem. So we know that here. So then we ask ourselves, what is the last variable? Are you compensating? So how do you compensate for a metabolic alkalosis? With the respiratory acidosis. And that's what's going on here. So you get the acidosis here, okay? So that's an immediate response. So you just have to walk through it step by step. Is it acidosis? Yeah, the stim definitely helps, right? If they give you something like vomiting or diarrhea, then you could pretty much clarify it right away. So if you know the symptomology, you can definitely differentiate it, right? So if you're vomiting, you're metabolically getting rid of acid, so you have metabolic alkalosis. So just make sure that the variables correlate. All right, Lindsay's going to go through
just a quick question I have.
Yeah, sure, no problem.
So today I was going through some practice problems. I ran into one where it had us differentiate between a mixed acidosis or a mixed alkalosis. Is that just by the pH, or because I think that the pH was acidic and then it was a mixed alkalosis was the answer?
That shouldn't be the case.
No? All right.
Yeah, no, because the pH is going to be the primary determining factor, right? You can't really have a, maybe it was a typo or something. I'm not sure. You could send it to me and I'll take a look.
Cool.
I'm not exactly sure, but it should be, that should definitely be a direct correlate to what's going on. So remember, yeah, you want to find the pH first, find which one correlates. Is it respiratory causing the alkalosis, or is it metabolic? And then you just want to know if there's compensation by the other mechanism.
All right, awesome. Thank you very much.
Yeah, no worries. Okay, cool.
Okay, so again, you can put your answer choices privately to me or Brady. Okay, we're getting a lot of answer choices for D, which is correct. Remember, ADH is going to bind to receptors in the collecting duct, and it's going to do the aquaporins, and that's how you're going to get water reabsorption. Oh, my key is wrong on this, Brady.
Okay, I can fix it. Yeah. Which, okay.
It should be B.
Okay, right.
Sorry,
So
the first time I wrote this question, I wrote descending, and for some reason I did ascending, and I put the same key. So what are we looking at here at the yellow arrow?
yeah, loop of Henle, right, exactly.
Mhm.
Remember, it's very clear.
And so in the loop of Henle, you have the descending and the ascending, and each side of that is going to be different because you have the countercurrent exchange. So the descending, so this is incorrect, guys, I'm sorry. Descending is selectively permeable to water. Ascending is selectively permeable to solids. And what this is doing is it's causing, it's gonna go hyper at the bottom, hyperosmotic, and then hypoosmotic at the very top. It's going to get pretty much the same as the medullary interstitium. So if we're talking about C, what would you find for C? What's part? Yeah, PCT. And I know there's a discussion going on if it's or DCT, I'm sorry. If it's distal convoluted versus distal straight or something. We were told DCT, convoluted. So if you have a question, I would email your professor because we said it's DCT. Everything that like Google first aid, everything says DCT. So I would confirm that. And then major site of reabsorption, what is that?
How would you know if this was the ascending versus a descending thin loop of Henle?
You wouldn't.
Okay.
You wouldn't.
Ascending thin is
The answer is B. The answer is B.
Yeah, we'll fix that when we post it again.
Yeah, ascending limb that's actively permeable for solutes, right? Not passive.
Yes.
Okay,
Yeah.
cool.
Yeah.
And not water. Water's descending, solids are ascending.
Yeah.
So the green one would be like the collecting duct, right?
Mhm.
Remember, it's more hazy. Talk about that.
Yeah, and then the beige one is the vasa recta. Yeah.
Which answer choice you said was DCT? I'm sorry, you said it was it?
Juxtaglomerular cells, yeah.
Isn't that macula densa cells?
Wait, where?
Oh,
What are we talking?
well, because the macula densa actually senses it and then signals the juxtaglomerular cells.
Right. It's just the osmoregulator.
Yeah. And so the juxtaglomerular cells are closer to the glomerulus, but it's the macula densa that senses. So it says it signals juxtaglomerular cells. And so it's kind of the next step in the process. So sensor versus where they're sending the signal.
I have a question. Will you see loop of Henle and DCT at the same cross section or not really? Because DCT is usually higher, right?
Yeah, you won't be able to differentiate. I mean, well, they won't make you differentiate. If they do, you'll either see this in the medullary part, or you'll see like the circular proximal and distal convoluted tubules. Yeah.
Yeah, and then C or D, hypoosmotic, that's when you get up. So at the DCT, that's where you're getting hypoosmotic, because at the very bottom of the loop of Henle, when you make that turn, that's when you're really, really, really hyper. And then you go up and up and up and up, and it actually gets like to 200 or 100 around there. So you're getting very hypo. So that's around the DCT area. And then major site of reabsorption would be proximal convoluted tubule. PSA is oh god, I always forget this.
The prostate specific antigen.
Yeah, it doesn't matter for you in term 1. Okay, we're getting a lot of answer choices for D, which is correct. It is the internal iliac. This was kind of hard for me because it goes, when you get to the ureters, it goes common iliac, and then you get farther down the ureters, it's like common external and internal, and then closer to the bladder, it says internal. I don't think they would give you the ones that it's multiple answer choices. I think they would do a part of the anatomy that is very clearly, okay, it's this. So I wouldn't really worry too much about that section where it kind of overlaps.
For the last question, how did you know that it was internal? Was it because you said it was at the prostate area, or just the bladder itself? So it's internal?
Bladder. Yeah,
okay.
Bladder.
Thank you.
Yeah. Okay, some people are choosing D, some people are choosing E. We're getting more for E. Okay. So remember that if you constrict something, everything distal to the constriction, you're going to decrease blood flow. And so if you constrict it at the efferent arteriole, which is after the glomerulus, anything distal is going to decrease the blood flow. So you're going to decrease the renal plasma flow, but everything proximal to that constriction is kind of going to back up. And that backup is going to cause an increase in hydrostatic pressure. So you're going to get an increase in GFR. And then, of course, the filtration fraction is a function of GFR and RPF. And so that is also going to increase because you get an increased GFR, because those are directly proportional. So remember that if you did the afferent arterioles, both GFR and RPF are going to change in the same way. So you are not going to get a change in the filtration fraction.
Yeah, that would be D. It would be for afferent.
Okay. I think everyone's pretty much agreeing on B, which is correct. So repelling negative charges, heparan sulfate is negative and like repels like, and so that is going to repel the negative charges. I'm pretty sure we had a question about that on our test. So it's an easy point if you remember it. So this is another acid-base one. So there are two ways to figure out what this is.
So in regards to that question, typically it's my understanding when you release engine, Brennan, the angiotensin is going to constrict the afferent arteriole. Yeah.
Okay, so we're all pretty much agreeing on D, which is correct. So there are two ways to figure out this question. Brady is actually that's increase, because my little chart says 7.35.
I thought, what? Okay.
Yeah, my little, yeah, my chart that I got off, it says 7.35 is going to be alkalosis.
Okay.
So that's what I went off for the exam.
Yeah, I think let's make this just because I don't want people to get
let's
confused.
do a little higher. I didn't want to make it crazy, but yeah, it's supposed to be an alkalosis. Yeah, 7.55 or 49.
Yeah, that works.
Okay. So we have an alkalosis. And so now what are you expecting with an alkalosis? With an alkalosis, you're either expecting the HCO3 to be what? It's going to be high.
Increased.
Yeah, it's going to be high, but in the CO2 is going to be low. So you know what you should expect. So now you look at the numbers and you say, okay, HCO3 is normal, so it's probably not a metabolic alkalosis. And we're looking at PCO2 is like, oh yeah, that really is decreased. So it's a respiratory alkalosis. But there's another thing in this vignette that tells you it's a respiratory alkalosis. What is it? Do you know? Aspirin, yeah, high dose aspirin is can cause a respiratory alkalosis. And the reason being, and that kind of sounds weird, the reason being it affects the respiratory centers in your brain. And so you're not going to, trying to think it would inhibit the respiratory centers.
No, it activates it because you
Okay.
get hyperventilation. Yeah.
Okay. So those are two ways, but tried and true, Ray, make sure you know those blood gases because that's going to get you to the answer. But if for some reason you can't get it, knowing the classic diseases that cause the metabolic or respiratory imbalances will help you narrow down if you're not too sure on the numbers.
And so you would have, yeah, go for it.
Just for the 7.39, when it was 7.39, I kind of just said acidosis, so I chose the answer with acidosis.
Okay.
So was that a fair approach, or does that make sense?
Don't like, so for the exam, just know that 7.35 to 7.45 is normal, and they'll give you values that exceed that.
Okay,
So,
but
yes.
for go straight to the pH and just make a decision based on that, is that fair?
Yes.
Okay, thanks.
Yeah, first step is always look at the pH because that's going to tell you what the body is in, because that's the actual condition, right? It's alkalosis versus acidosis. That's the problem. Now you have to figure out what's causing the problem, and what's causing the problem is either, respiratory etiology or metabolic etiology, and that's where the other numbers start coming into play. But the deviation from pH normal is what's actually the issue.
So remember, this is short acting, right? She probably was found within hours of this, so that's why you don't get any compensation. You would get compensation if it was over a longer time frame.
Yeah.
What would be an example for choice A?
Normal ion gap would be diarrhea, renal tubular acidosis,
acetazolamide.
Yeah, and then chronic aspirin use.
I put a graph from first aid that has a list of everything. The ones that are non-anion gap, I think the mnemonic is mud piles. So you can look at that. But anything that falls in the anion gap category, typically it has to do with bicarb, directly CO2 or chloride. Those are going to be normal anion gap.
I have a question. Like in that case, if you change the scenario and you say like 72 hours, the patient had the same situation, it would be metabolic acidosis with normal anion gap because it's compensating already.
Well, you would say not necessarily, no. You would say, but you would say there would be metabolic compensation.
Yeah.
So you would expect the bicarb to go up, but but it would still,
Chronic use is more over an extended period of time where the body starts to adjust to what you're putting into it. But to that, exactly what Brady says, if it was 72 hours later, your body has started compensating. So it would still be a respiratory alkalosis, but it would be compensated respiratory alkalosis.
Yeah, and look, if they give y'all a problem that has to that asks you if there's anion gap, they'll probably just ask you to do the math, right, and just calculate the anion gap and see if it falls in the right range. That's as far as they're going to go. For these questions, it's going to be straightforward. it's going to be something like this, and they're going to give you one of these answers.
Mm-hmm.
Oh, mud piles. It's like methanol. I forget. I don't know. It's in. You could just Google it, and it's also in first aid. Like mud piles, uremia, some other stuff. Stuff that you really haven't talked about too much.
Okay, we have some answer choices coming in. It looks like we're all getting this concept.
Are A and D the same answer choice?
A and B?
A and E.
A and E.
Oh, yeah, they are. Sorry, guys.
No worries.
It's not the right answer, so yeah, it's C, isoosmotic volume contraction. And you know it's isoosmotic because when you're vomiting and you have diarrhea, you're losing everything that goes with it. You're not just losing water and you're not just losing solutes, you're losing both water and solutes. And so it's iso, you're not taking one thing out of the equation. So it's isoosmotic volume contraction because you're losing volume there.
I have a question. Would a hemorrhage be an isoosmotic volume contraction as well?
Yes, because you're losing everything in the blood, not just water, not just solids.
Thank you.
Mm-hmm. Yeah, I don't think she had hemorrhage on the slide, but I know she said it because I wrote it down in my notes. So. Okay, we're getting more answer choices for C, which is correct. It's the sodium chloride potassium co-transporter. So make sure that you draw out all of the diuretics and you know their mechanism of action and where they act on the nephron, because that's very important. You need to know both of those pieces of information.
You right. So furosemide, remember, is a loop diuretic. We were just saying that hemorrhage is isoosmotic because you're losing the solutes and fluid along with the hemorrhage. So it's a volume contraction that's isoosmotic.
Yeah, it's B. Everyone's answering in B.
All right, sweet. Right, bring all that glucose back in. You want to keep it. Previous question, this one. So remember that furosemide is a loop diuretic, and this sodium chloride potassium co-transporter is found in the loop of Henle. So that's just asking you if you know what the diuretic is and where it works at. All right, I will post everything hopefully tonight, unless I have any problems, but I think everything will go good. If y'all have any questions, go for it.
Good luck.
Yeah, good luck. Y'all got this.
Thank you so much.
Yeah, no worries.
Thank you guys so much.
Thank you. Let us know if y'all need anything before your exams, but y'all do great. Y'all be fine.
Thank you so much.
Yep.
I just have a question for the
yeah, I have a question too.
Yeah, go for it.
My quick question is, would you guys recommend going through all those modo questions to prepare for like the test, like for the respiratory stuff, the renal stuff? Do you feel like it's going to be that intense?
If you feel like the modo questions help you, then go for it. I have kind of a love-hate relationship with the modo questions because I feel like some of them can get a little too intense, and I've found mistakes in some of them. So I'll do it as long as I feel it's helpful, but this close to the exam, I don't know if I would actually go through modo.
They haven't posted a lot of chiropractic problems. That's why I'm like, and they expect us to know these concepts without really like giving us examples of application or giving us any.
Yeah.
That's why I'm like, is modo where to go?
Well, modo also doesn't have, it's not vignette styled. It's very ask a question, give an answer style. And so I don't know if that's the best right now. Modo, for those of you that don't know, is a set of questions. Like the questions are sets are like 300, 400 questions long that a DES group of the past put out. And a lot of people use them to study. They're from the SNL group, I believe. So they're still floating around. Yeah, BRS is good.
Yeah, Guyton too. Yeah.
Yeah.
I would, if anything, I'd probably put Modo to the end just because I would try to focus on more of the vignette style questions.
So where would you recommend getting questions? Because Sakai is not really giving us
The
any.
BRS and Guyton.
Okay.
So I think I have PDFs of those, honestly, that I can put in my Google Drive.
I'm so glad you guys are telling me this now because I was about to start freaking out over Moto, but you're saying BRS and Guyton.
Yeah, for sure. And
yeah,
old IEA questions are good too. I posted a bunch of questions on the drive as well for
Are
old
they
IEA questions. What's that?
Because I feel like they're just kind of like conceptual, but none of them really have the formula questions because that's where I'm struggling.
Yeah, I would go to
I don't-
Guyton and BRS, yeah, for sure.
Yeah, so
Also,
I have a
look at the
question.
alternate sessions for the IMCQs. They have different questions if you haven't.
Yeah, they do that for us too. It's really good. I found the BRS, so I'm going to go put that in my Google Drive right now if my computer cooperates with me.
So I do have a question with the glomerular filtrate rate with the neuroregulation where we have the sympathetics, right? So in situations, I saw a question and I kind of got confused with when you have like hemorrhage or dehydration, and then when there's like little changes, how that renin, is there like a difference?
Well,
on
if
how
you
it operates?
Well, no, I mean, the renin is going to be a direct correlation to the osmoregulation. So if it's determined that you're hypotensive for whatever reason, you don't have enough blood volume, that's going to secrete renin. So it's pretty generic across the board. Because you want to clamp down on the vessels to bring the blood pressure up, and you also want to reabsorb a lot of the fluid at the collecting tubule with aldosterone. So it's my understanding, if it's determined that you're hypotensive, then that's the route you would go.
Okay, thank you.
Question about, and I don't know if we need to know this, so if we don't, I'm not going to bother myself over it, but I understand the negative charge of the heparin sulfate. I got that question right, but do we need to know anything beyond that, like what role it plays, like in the basement membrane or whatnot?
I don't think so, no.
I think the most important thing is just repelling the negatively charged ions, honestly.
I won't say it then, thank you.
Lindsey, can you post a link to your drive?
Yep, getting that now. It's not too robust. I'm going to use this break to like make it better, but there's a lot of books in there.
I have a quick question about the ECV volume and ECF volume for stalling forces. And I'm just a little confused with the oncotic pressure and the osmotic pressure. Because like there was a question that asked about the effects of ECF on stalling forces. And is it because of a decreased or an increased osmotic pressure? And I still don't get the concept of it.
So, okay, so so an oncotic pressure is the same thing as saying an osmotic colloid pressure. They're the same thing. So that's probably what they're talking about. It's the same thing.
Okay, so when there is a higher osmotic pressure, what would happen to ECV?
Well, it's osmotic colloid pressure. That's what they refer to it. So if that's the case, and it depends if it's in the capillary or if it's in the interstitial fluid, right? So it depends where this protein concentration is, because regardless of where it is, it's going to have that pulling factor, right? Remember, hydrostatic pushes and oncotic pulls. But I guess you could use it extracellularly versus intracellularly the same way. If you have a lot of solutes or proteins outside the cell, it's going to pull water out of the cell. You kind of did that in FTM.
Thank you.
Yeah, no worries.
So I just had a question for the lab exam portion. I feel okay with the OCEX. Like I barely studied and I got like a 90 on the practice one. But the lab practice quizzes that they have posted on Sakai, is that going to be a lot of the high yield like images that they want us to do? Because there's a ton of images in our lab books that they recommend, like between McMinn's and the Grays.
So with the images that they recommend, what you're going to notice going through is that they're the same part of the body, but you just have different cuts or deeper cuts, or they're focusing on different things. And so I did screenshot every single one of those pictures and put it up. But what it helps you do is solidify everything. So I would go from one picture, I would identify it, and I would go to the next picture. I was like, oh, that's what that is. I would go to the next picture. Oh, that's what that is. And so it's not like 30 pictures and they're all different things. It's 30 pictures and they probably show you 5 or 6 things. And so it's not as bad as I thought it would be, and it's probably not as bad as you think it is. But how I did it, this is how I personally did it, and I did well on this exam. I went through, I did the quizzes, and then you go back where it says feedback, and then it shows you the answer to the quizzes. I screenshotted all those answers, and I wrote the answers down in my OneNote. And then I screenshotted all of the images from the atlas. Then I went through and I made sure that I could identify every single structure on every single image. And anytime they had a second order question, I made sure I could answer that second order question for every structure in the image. And then if there was something that I wasn't too sure on, I went back to my lecture notes. I would copy and paste a little screenshot there to make sure that all of my concepts I was solidifying for each of those images. They're probably going to use a lot of the same images, but they probably won't point to the same thing. We were talking about that this morning in the pulmonary session. But yeah, that's how I did it. I did really well on both of those exams. So it's a lot more straightforward than you think it's gonna. I thought I was going in there ready to fail that exam and be like, okay, it's only worth 30 points of my grade, like it's fine, because I didn't know what to expect, and it was extremely straightforward. But I mean, I had gone over the images really well, and so when there was an image that was pointing to something else, or it was like a weird structure, I knew what it was. But I mean, I didn't spend too much time on it, honestly. It was the night before.
It's more just like it was more, I started screenshotting all of the images and from both of the books that they tell us to, but it became very like time consuming, and I'm like, dang, do I need to spend a lot of time on this one, or should I be focusing on like our actual block exams and stuff? So, but I did all the lab quizzes today that were on Sakai, and it wasn't anything that I hadn't seen before, but I didn't know if it's gonna like the hardest questions for me that they had posted were the second order like embryo questions. Like they pointed to the aortic arch or the ascending aorta and said like, hey, what's the embryological derivative or whatever. Yeah. So I
thought the lab exams had more, the practice ones had more second order questions than actually the actual exam did. It may have been like 70% first order questions. So I wouldn't stress about the embryo stuff.
Oh, okay. They only had a couple, just, I mean, like maybe out of all 5 of them, maybe like 4 or 5 questions for embryo. So it wasn't too bad, but I didn't want to go really past the lab quizzes if I didn't really need to.
Yeah, that was by far the most high yield stuff. So I would start there for sure.
All right. Thank you guys.
Yeah, no worries.
Yeah.
All right, I'll go ahead and stop the recording. We're good.